Good morning, everyone. Welcome to APTCon 2022, the annual CME of APT, organized by Association of Pulmonologists Thrissur under the aegis of APCCM. For official welcoming, I invite Dr. Thomas Vadakan, sir.
Good morning, one and all. On behalf of the team APT, we are conducting APTCon 2022. Omicron 2022 was a challenge for APTCon 2022. We overcome this by making our conference in a hybrid platform. We have both offline and online, and this time our conference in a special way that we have 8 selected case competition today, and in between we have 2 orations. The first oration will be Dr. Nadraj Iyer Memorial Oration, which will be done by Professor C. Ravindran, sir. And the second one, Dr. N. Mohanan Memorial Oration, which will be done by Dr. Kurian Thomas, sir. And we have an interesting CPC also. And end of the session, we will be declaring the results of case presentation. So once again, wish you all the success and a good conference experience. And let me invite the judges of the case presentation, Professor C. Ravindran, sir, and Professor T.P. Anni, sir, to the dais. Thank you.
Good morning, everyone. So we are starting with our case presentations. The judges for the day is Dr. C. Ravindran and Dr. T.P. Antony. Dr. C. Ravindran, MBBS, MBA, MD, DTCD, FRCP, is the current Senior Consultant and Chief of Medical Services in Baby Memorial Hospital, Calicut. He had executed the role of Principal, Government Medical College, Kozhikode, along with being the Head of Department of Pulmonary Medicine in various institutions. He has been a member of numerous councils, the Board of Studies and Chairman, RNTCP, State Task Force, Kerala. The doctor also has numerous published research papers under his name. He is currently the Section Editor, Lung India, and member of various editorial boards too. It is with great pleasure that we invite him for this session. Dr. T.P. Antony graduated from Trivandrum, his MD in 1976 and MNAMs in 1981. He has been an invaluable asset of various government medical colleges, Kottayam for 13 years, Calicut for 1.5 years as professor, and Thrissur for 13.5 years as a head of the department. He is an examiner for MBBS, MD, DNB, and MRCP. He has been a part of Amala Institute of Medical Sciences for 14 years and is now an adjunct professor at Amala. We invite you, sir. Starting with the case presentations. First off, we have alveolar adenoma in a patient with LAM.
Good morning. Today I am going to present a case of a 36-year-old female patient from Alappuzha, homemaker with no known comorbidities, who presented to us with complaints of gradually progressive breathlessness on exertion and generalized tiredness 7 years back. She does not have any history of fever, cough, or chest pain, no history of orthopnea, PND, pedal edema, weight loss, or loss of appetite. There is no history of any pneumothorax, pleural effusion, renal diseases, or neurological diseases. She is married and has 2 children, and there is no significant family history. On examination, she was moderately built and nourished. Her general examination was normal, and her respiratory system examination was unremarkable. So radiology, and all the X-rays are reported to be normal. They are not available. This is a recent X-ray which showed a well-defined round opacity in the right lower zone with no obvious cystic lesions. A CT taken in 2014, reports were available. It shows multiple well-defined, thin-walled and regular cystic lesions diffusely distributed with intervening lung normal, possibly lymphangioliomyomatosis. There is also a well-defined soft tissue density in lesions in posterior basal segment of right lower lobe and posterior basal segment of left lower lobe. Her blood investigations were normal and ANA profile was negative. She was given symptomatic management and was kept under our follow-up and was advised a repeat CT at follow-up. A repeat CT done in 2016 showed that the cystic lesions remained the same and the size of the lesion in the left lower lobe remained the same. But the lesion in the right lower lobe has quadrupled in volume in the last 2 years, now measuring 2 into 1.94 centimeter. She was advised a PET CT. It showed 2 large fat density nodules in posterior basal segment of bilateral lower lobes. The larger one was measuring 20 into 19 millimeter on the right side, and both of these were FDG non-able. She was kept under follow-up, and repeat CT was again done at follow-up in 2017. There was no significant increase in the size of lesions. After this, she was lost to follow-up for a brief period. She presented again in July 2021 for a routine follow-up. There was no significant worsening of symptoms. Her physical examination was unremarkable. 6-minute walk test done showed no desaturation, and the distance was 350 meters. A CT was done which showed that compared to previous CT, the number of cysts and the size of soft tissue density has increased. So these are the CT images showing well-defined multiple cysts bilaterally. This is an image showing a well-defined rounded enhancing soft tissue density nodule in posterior basal segment of right lower lobe, measuring 2.6 into 2.3 centimeter. A similar lesion is seen in the left lower lobe also, but it has a cystic component. So she underwent wedge resection of the right lower lobe nodule with removal of lymph node. So moving on to the pathology of the resected specimen, the gross specimen weighed 24 gram. On section, there was a multiloculated clear cyst which drained clear fluid, and the inner walls were smooth. So microscopy, you can see a circumscribed neoplasm composed of numerous cystic spaces of varying sizes. There's peripheral lung tissue with central cyst, and there's a characteristic arrangement with larger cyst towards the center and smaller cyst towards the periphery. Lining cells also showed hobnailing of nucleus, and when IHC was done, they were positive for cytokeratin and TTF1. CD34 was only positive in the blood vessels, and the lining cells were negative. SMA, which is a characteristic marker for LAM, was absent in the stromal cells of the stool. So all these findings are consistent with alveolar adenoma, and the lymph node was a reactive change. So discussion, lymphangioliomyomatosis is a multi-system disorder which occurs sporadically or in association with the genetic disease tuberous sclerosis complex. It is characterized by cystic lung lesions, abdominal angiomyolipomas, and lymphatic abnormalities including lymphatic tumors and chylous effusions. There are two types of LAM, sporadic LAM seen in females and inherited LAM tuberous sclerosis complex seen in males and females. They have associated neurocutaneous findings. So the complications of LAM include pneumothorax, which can occur in 2/3 of patients, and initial presentation in 36%, which is often recurrent also. Lymphatic involvement in LAM includes lymphadenopathy, lymphangioliomyomas, chylothorax, which is unilateral and right-sided, and rarely chylosositis or chyluria. Chest X-ray usually range from being normal to showing a reticular or nodular shadows or severe cystic changes. CT features characteristic of LAM include multiple thin-walled, round, well-defined air-filled cysts with preserved or increased lung volume, no other significant pulmonary involvement, and there should not be any ILD with the exception of multifocal micronodular pneumocyte hyperplasia in patients with tuberous sclerosis complex. So these are the CT images showing well-defined, round, thin-walled cyst with no preferential low involvement. So diagnosis is done. We say it is a definite LAM when there's a characteristic HRCT and a lung biopsy showing the pathologic features of LAM, or a characteristic lung HRCT and an angiomyolipoma, chylous effusion, lymphangioliomyoma or lymphadenopathy, or tuberous sclerosis complex. We see it is probable LAM when there is a presence of a characteristic HRCT and a compatible clinical history, or a compatible HRCT and angiomyolipoma or chylous effusion. It is possible LAM when there is presence of a characteristic or compatible HRCT alone. Serum VEGF-D is increased in patients with LAM. Levels more than 800 picogram per ml is highly specific. We could not do this in our patient because the patient couldn't afford this test. Now about alveolar adenoma, this is a rare benign tumor. Approximately 40 cases are described worldwide in English medical literature. It is usually a solitary pulmonary nodule in asymptomatic patients and more frequently in the middle-aged women. Usually peripheral, subpleural, coin-like, middle or lower lobes are affected. Although benign, there is a single case report showing malignant transformation into adenocarcinoma. Radiology, these are usually well-circumscribed lesions with smooth borders. Some case reports describe nodules with small cystic spaces, and it's a single case report which describes it as a symptomatic cavitary mass. CT in most cases demonstrate no enhancement or spotty or mild enhancement. So these are the CT images showing a well-defined, smoothly marginated nodule. Management of LAM, we should avoid sports involving physical contact because of risk from bleeding from AML. Hormonal therapy, matrix metalloproteinase inhibitors, statins, and inhibitors of autophagy has been tried in various trials. mTOR inhibitor sirolimus is indicated in patient having a declining lung function with FEV1 less than 70% of predicted or symptomatic chylous fluid accumulation. Alveolar adenoma management is surveillance with serial imaging, and surgical resection is always curative. So there are only very few case reports showing alveolar adenoma in LAM. There's a case report by Landry-Joel who reported a patient with 21-year-old female with tuberous sclerosis, CT showing nodules, and when biopsy was done, it was suggestive of alveolar adenoma. This is an old case report published in 1975 by Brian Corin. In this also, he reports one case of a patient with LAM having a nodule. Biopsy was suggestive of alveolar adenoma. So our patient was not affording VEGF or sirolimus. Sirolimus was not indicated also, and plan for the patient is to keep under regular follow-up. An RT referral was done after the biopsy. They said no need of an active intervention at present. So this case is being presented here because of its rarity in medical literature. Alveolar adenoma is an extremely rare benign tumor of the lung, usually presenting as a coin lesion in an asymptomatic patient. Case reports of alveolar adenoma presenting with LAM are scarce. Thank you.
Very nice presentation, very well done. May I ask you, what was the doubling time of this lesion you have demonstrated? What was the doubling time? You said the mass was increasing in size. What was approximate doubling time?
Sir, I cannot hear you, sir.
Asking about doubling time of your adenoma.
Sir, in 2 years, it has actually quadrupled in volume in between the 2014 and 2016.
What's your plan for the adenoma on the opposite side? How are you going to follow it up?
For the time being, we are keeping it under regular follow-up, sir.
Dr. Shahina, you presented a very rare case. Thank you very much. Lymphangioliomyomatosis, usually LAM is associated with lymphangioliomyomas, isn't it? Not adenomas. Why there is adenoma in this particular case? What is the mechanism?
Sir, all the previous case reports mentioned that these two LAM and adenoma are histogenetically and phylogenetically different. So these are both LAM and adenoma are different, two entities existing in the same patient. Sir. Also,
so you want to say that this is only an association, independent lesions, isn't it? Not related to the LAM, but there are case reports. You said that there are case reports where adenoma is reported in LAM.
Yes, sir. 2 case reports I could find where an adenoma was reported in a patient with LAM. But in that also they have found that when they did the IHC, the markers they found in adenoma and LAM were entirely different. The LAM markers were not found in adenoma.
Usually LAM is seen in young females, isn't it?
Yes, sir.
Very rare in males.
So my patient is female.
It's a female? Okay.
It's a female.
Okay. I thought you are going to present a PLCH because cystic lesions with solid nodular lesions usually go with PLCH. But this is LAM with adenoma. I haven't seen such a case so far. And your cyst, upper lobe cyst which you have shown is not a typical LAM cyst. Wall is very prominent. Usually LAM we don't get that prominent wall.
Yes, sir. Sir, we also had a discussion with the radiology. So other cystic diseases, none of them were fitting into this profile of CT of this patient. So they have also kept it as possible LAM only after reviewing the CT.
Okay. Is there any association of tuberous sclerosis in this case?
No, sir. No stigmata of tuberous.
So what are the manifestations of tuberous sclerosis, extrapulmonary?
So there can be major features and minor features. The major features.
I can't hear you. Louder, please.
Hello, sir. Hello.
Tell me.
So the major features and minor features. The major features include periungual fibromas, angiofibromas, shagreen patches, hypomelanotic macules, retinal hematomas, cortical tubers, subependymal giant cell astrocytomas, and the minor features include renal renal malignancies. Sorry, major features itself, angiomyolipomas, and then so the
Okay, good.
shagreen patches.
Okay, you have enumerated almost all. Thank you. Any other questions? So there are no questions from the audience. Thank you, Shahina. Thank you for the excellent presentation.
Thank you. Next up, we have our next case, a gravid lady with respiratory failure.
A very warm good morning to everyone. Myself, Dr. Abarna S. Narmal from Rajari Hospital, Cochin. I would like to present a case of a gravid lady with respiratory failure. As the story unfolds, she was a 26-year-old lady, primigravida, at 31 weeks of gestation, no known comorbidities, no allergic background or addictions. She presented to us at 3 weeks with cough, which was non-productive, progressive shortness of breath, anorexia and easy fatigability. There was no fever, chills or weight loss. She was afebrile at the time of presentation. She was tachypneic with a respiratory rate of 34 per minute, and she had tachycardia. Accessory muscles were active. Saturation was 93% on room air. She was pale, and there was palpable lymph nodes in the axilla. On respiratory system examination, trachea was shifted to left. There was reduced movements of chest on right side. Apex meter shifted to left side, 1 centimeter lateral to the midclavicular line. Stony dull knot and percussion was noted in the right mammary, infraaxillary, scapular, infrascapular areas. There was absent breath sound and reduced vocal perimeters and vocal resonance in the corresponding areas. On obstetric evaluation, abdomen, uterus was corresponding to 30 weeks of gestation, cephalic presentation with adequate liquor, and fetal heart rate was 140 per minute. This was the chest radiograph at the initial presentation. As you can see, there was silhouetting of the right diaphragm with blunting of the right CP angle, and there was obvious mediastinal widening. What are the causes of pleural effusion in pregnancy? These are the possible causes. Most commonly infections, which includes parapneumonic effusion and tubercular effusion, connective tissue disease, possibly SLE, pulmonary embolism, could be a malignant effusion with, due to lymphoma, gestational trophoblastic disease, or carcinoma lung, or lymphangioliomyomatosis. We went ahead with the baseline test. Initial investigation with blood routine showed that she had anemia with a HB of 9.5. Counts were slightly elevated, borderline elevation with 11,700 cells per cubic millimeter. Her renal, liver and thyroid functions were normal. LDH was elevated with 744 units per liter. Urine routine showed no proteinuria. Peripheral smear showed hyperchromic anemia with relative neutrophilia and lymphocytopenia. ANA and RA factor were negative. Her initial evaluation with sputum test, gram stain, culture, AFB smear, cytology were negative. Echo was normal. Ultrasound chest showed moderate right pleural effusion with a hypoechoic mediastinal lesion. We went ahead with the US-guided pleural fluid analysis, pleural fluid aspiration, and the analysis yielded pale yellow colored fluid, exudative effusion, which was lymphocytic predominant. Cytology was negative for malignant cells, and which showed predominantly small lymphocytes. ADA was elevated. Culture and gene expert were negative. As the initial investigations were inconclusive, we went ahead with a CT chest with contrast after getting informed consent from the patient and family, as well as in concurrence with the gynecologist. With abdominal shield, we went ahead with the CT chest. As you can see in the image, there was a large, relatively heterogeneous mass lesion in the mediastinum, which was almost encasing the major blood vessels, and a moderate right pleural effusion. There was also some amount of collapse consolidation in the adjacent lung with some amount of ground glassing. So what are we dealing with? Possibly a lymphoma or a germ cell tumor or a primary carcinoma of lung or a sarcoma of lung. These were the DDs that we kept in mind. And we decided to proceed with a true cut biopsy of the mediastinal lesion, as we went ahead with the USG guided because possibly it was a superficial lesion and no further radiation exposure to the pregnant lady. Histopathology yielded intermediate to large size lymphoid cells separated by compartmentalizing fibrosis, moderate to abundant clear cytoplasm and vesicular nuclei, small foci of necrosis, and red Steinbach cells and granulomas were absent. We went ahead with the immunohistochemistry, which revealed strong positivity to CD20 and CD23 and BCL2, and weak moderate positivity to CD30, and K index was around 70 to 80. So with this, we came to a diagnosis of primary mediastinal large B-cell lymphoma. So in front of us, there were so many dilemmas. The salvageability of the fetus, when to intervene with the obstetric intervention, what time we should start the chemotherapy, what choice of regimen we should start, and how do we manage the pleural disease. So we went ahead with a multidisciplinary team discussion involving the pulmonologist, hematologist, oncologist, obstetrician and the critical care team, and we came up with following decisions. Attempt to salvage both mother and baby, and try to treat her initial symptoms and pleural disease with tube thoracostomy. And once the lung is expanded and the drain is less, attempt a pleurodesis. Simultaneously, a pre-phase chemotherapy was instituted with the cyclophosphamide and prednisolone. This was decided after a discussion with the National Forum to decide on a safest chemotherapy in pregnancy, and then induce the labor at 34 weeks of gestation, preferably a normal vaginal delivery. Then following delivery, do a staging evaluation with PET, bone marrow and CSF studies, and start her on RDA epoch regimen after delivery. So we started with a pre-phase chemotherapy soon after the histopathological confirmation with injection cyclophosphamide and tab prednisolone. Cyclophosphamide was started at a dose of 1184 milligram IV on first day, followed by prednisolone 90 mg daily for next 5 consecutive days. And labor was induced at 34 weeks of gestation. And following which, staging of investigation was done with a CSF analysis and bone marrow study, which was normal. There was no CNS involvement, and went ahead with a PET scan that revealed heterogeneously FDG large mediastinal mass lesion, as you can see in the PET CT images. Following that, we went ahead with the RDA epoch regimen, which was initiated after 1 week after delivery, which consisted of rituximab, doxorubicin, etoposide, prednisolone, vincristine, cyclophosphamide, and methotrexate. Finally, the maternal and childhood outcome was she had an uncomplicated delivery, unremarkable postpartum course, and short NSICU stay, and she coped up really well. There was good response to RDA epoch regimen and no reaccumulation of fluid, and till date 5 cycles have been completed and she is doing good. And this was the follow-up images. As you can see, there was good resolution of the mediastinal lesion, as well as the pleural disease, and the metabolic activity has greatly reduced. And take home from message from this case is, whenever a pregnant lady presents with respiratory symptoms, we don't hesitate to order a chest X-ray or a CT thorax in necessary cases, especially when there is moderate to severe symptoms, hypoxia, lack of response to initial treatment. And lymphoma in pregnancy, definitely it's a dilemma, and regarding the fetal salvage, timing of chemotherapy, etc. For that, always better to take up a multidisciplinary team discussion, and which we can have a better outcome. And this is definitely an aggressive tumor, so we had to proceed with an extremely aggressive regimen as well. Thank you.
Thank you. Very complicated case, well managed and well presented. All was well and attended well also. That's good. Now, can you just tell me how much exposure of radiation you have when you have one single chest X-ray to a patient?
Sir, single chest X-ray, the expected radiation is around 0.001 millisievert unit.
And CT scan?
CT scan, it can range from 1 to 2 based on whether contrast is given or not. And at times we can even reduce the radiation dose also in that case.
Thank you, Dr. Abarna, for the excellent case. Your message is very clear, because you can take X-ray or CT if mandatory in a pregnant lady. Especially this lady is in the 3rd trimester, isn't it?
Yes, sir.
So naturally you can go for X-ray or CT. But my question is, you have a wide mediastinum. And why can't you go for an EBUS before an investigation like CT with contrast? Because EBUS, you have done an ultrasound for the pleural disease, and EBUS can tell you what exactly is there in the mediastinum. And even you can attempt a biopsy without exposing the patient to radiation.
So as you said, EBUS we could have done, but the one of the main parameter was she was in so much of respiratory distress, and clinically subjecting to her to general anesthesia and doing a procedure was seemed to be more riskier at that point of time. She to avoid that, maybe we could have we had to go ahead with a USG guided biopsy.
This CT with contrast is okay, but there are certain problems because we know that during pregnancy, especially in the last trimester, kidney function may be a little bit compromised. So when you give a contrast, naturally there is a chance that the patient may go for renal failure. And fetus also has got its own risk also. So mediastinal EBUS is an easy investigation, even though you said that general anesthesia is difficult. The distress is mainly due to pleural effusion. You could have removed the fluid, and even intercostal drainage at that stage, I don't know whether it was mandatory or not, because lymphoma is a disease which will respond even to steroids. So you may have a transient improvement when you give steroid in this patient, because steroid can be given at that stage, 30 weeks of gestation, and patient will be symptomatically better. You can do the other investigation. I'm not questioning the authority of the investigation, but we can plan like this also. This is another alternative route for this particular case. And giving chemotherapy and all, you know that lymphoma is far advanced, and we can typify the disease and put on chemotherapy, and patient has got a very good response also for treatment. So in that way, it is a good disease for the patient, even though it happened in the pregnancy stage. Okay, thank you very much. Any questions? Dr. Anis, please.
Yeah, good morning. My question is, why not going for a biopsy via medical microscope? During your chest view. Just my view, may be only FNAC. So it may be meaning a biopsy. You are the one. The FNAC may not, the members may not be satisfied with an FNAC from because they need a biopsy specimen for more staining and analysis. I have two questions. Why you didn't go for medical microscopy and get a biopsy from fluid tissue that may also yield lymphomatous cells? And second question, have you gone for bone marrow studies in this case?
Yes, sir. We had and go ahead with bone marrow, both aspiration and biopsy to see the CNS bone marrow involvement. Metastatic workup was done post delivery, and why we didn't go ahead with a thoracoscopy and getting a biopsy was in ultrasound itself there was an obvious large mass lesion which was superficial, which we could access it much easier through a small, like we actually did not FNAC, biopsy only we got it done. We could access it through ultrasound with through a minor procedure. So that was one reason we didn't go ahead through thoracoscopy. And one more thing our hematology and oncology team suggested was less interventions because she had to be started on a very aggressive regimen to avoid such invasive procedures as much as possible, like to prevent secondary infections and sepsis and all those. We wanted to subject her to less procedures. That is why even we wanted to proceed with a normal delivery rather than a cesarean session also. That was one of the reasons we didn't want to subject her. And
thoracostomy and thoracoscopy. I don't see much difference. If you are going ahead with the ICD, even though it's not mandatory, if you are going ahead with the ICD, you can have a view with a biopsy. I mean a thoracoscope.
Why we had to go ahead with an ICD was not in the initial stage, sir. it was an aggressive tumor. So initially we did only a diagnostic aspiration. So within few days, she had developed a massive effusion and with mediastinal shift. So in that case, her respiratory failure was worsening really bad. So in that case, we did a therapeutic aspiration, and almost 1 to 2 liters was drained over 2 days. Instead, even then the pleural effusion was really making her more like respiratory distress. There was a lot of respiratory distress in spite of that, and her respiratory failure was worsening, and there was rapid accumulation of fluid. That is why after multidisciplinary discussion, we decided, okay, we'll go ahead with an ICD for a better symptomatic relief, and better like respiratory failure has also improved after that. It was not the initial stage that we decided an ICD.
Any preference for a pleurodesis agent in a pregnant woman?
We did with poudonidine, sir.
Patient had a few lymph nodes, no?
Yes, sir. Axillary lymph nodes were palpable.
Were they large enough to be biopsied? In which case, you would have got the diagnosis from there itself?
We did not do that initially because there was a large obvious mass, mediastinal mass, which was superficial and accessible. So obvious lesion was visible to us, so we decided to go ahead with the primary itself. And in the PET scan also there was no when we analyzed the PET scan also did not show any uptake in the axillary lymph nodes. Probably it was reactive lymphadenopathy, sir.
Thank you, judges. Now we have the last case of this set, case 3, don't judge a book by its cover.
Good morning. I would like to present a case titled Don't Judge a Book by Its Cover. I would like to remind a quote by Sir William Osler that medicine is a science of uncertainty and an art of probability. History: a 19-year-old girl, higher secondary student, hailing from Thrissur with no known comorbidities and drug allergy, was referred for evaluation of left paraganglioma. Revisiting the past, she presented with intermittent headache and blurring of vision during August 2021. She had history of loss of weight, approximately 5 kgs in last 2 months. Then she consulted an ophthalmologist which showed features of bilateral papilledema. She was then referred to a neurologist wherein she was suggested with MRV and MRI brain. MRV was normal. MRI brain showed bilateral prominent CSF spaces around optic nerve. She was planned for lumbar puncture. At the time of LP, her BP was found to be 200 by 110 millimeter of mercury, and ECG and echo then showed a normal heart. She was worked up for causes of secondary hypertension, and MRI abdomen showed enhancing well-defined paravertebral lesion adjacent to left kidney, which was hypointense in T1 and remains hypointense in T2 weighted images. Both the adrenals were normal. So she was then referred to our hospital in ER. She complained of headache, palpitation 1 episode, and blurring of vision since 2 months. She was referred for evaluation of secondary hypertension with a provisional diagnosis of left paraganglioma, and she was admitted under endocrinology. She denied any history of fever, sore throat, chest pain, cough, abdominal pain, vomiting, diarrhea, syncope, joint pains, hyperpigmentation, hirsutism, sensory or motor weakness. Her father had CAD, history of CAD, status post-CABG at the age of 35 years of age. And on examination, her general examination, no pallor, icterus, cyanosis, clubbing, lymphadenopathy or edema. Her weight at the time of admission was 46 kg. Her vitals were normal except for blood pressure, measuring 170 by 110 millimeter of mercury. Other systemic examination were normal. The chest radiograph at the time of admission was grossly normal. So blood investigation at the time of admission, her total counts were 13, followed by HB of 12, ESR of 12, and CRP of 35. Other parameters were grossly normal except for serum potassium measuring 2.8 milliequivalents, which was found to be low. So differential diagnosis considered at that point were pheochromocytoma, Conn's syndrome, renovascular hypertension, renal parenchymal disease. So we repeated an ECG and echo. So ECG was normal. Echo showed grossly normal with grade 1 diastolic dysfunction. USG abdomen with renal artery Doppler was done to rule out other causes. So it showed bilateral raised renal echo texture with maintained corticomedullary differentiation. Bilateral main renal artery showed normal Doppler studies with normal adrenals. So a DTPA scan was done to assess the renal perfusion, which showed bilateral mildly reduced cortical tracer distribution consistent with bilateral mild renal parenchymal dysfunction. So there was hypokalemia. We initially thought it might be due to shift hypokalemia due to metanephrines. Urine potassium creatinine ratio were 25.5, which was elevated. 24-hour urine potassium was 19, borderline. She had hyperuremic hyperaldosteronism, and overnight dexamethasone suppression test was done to rule out Cushing's causes of secondary hypertension, which was found to be negative, and serum metanephrine was also found to be normal. So our timer was running, the patient still had blood pressure. So we took a second opinion of outside MRI from our radiologist. He suggested that it might be a paravertebral mass lesion adjacent to left kidney, which might be extending into thorax. Hence, we did a CT chest and a CT abdomen. So CT chest showed a few mediastinal lymph nodes, mainly subcarinal lymph nodes as I have described here, and a paravertebral mass lesion which is adjacent to left kidney. Hence, a multidisciplinary team meeting was formed with endocrinologists, respiratory medicine specialists, radiologists, and medical oncologists. And our differential considered at that point were a benign mass lesion, malignant mass lesion. It could be an infection or a miscellaneous cause with herniated disc, spinal aneurysm, hematoma. So MDT decided to do a PET CT. So PET CT showed FDG avid mediastinal lymph node lesions and a FDG avid paravertebral lesion, which was adjacent to left kidney. And both the kidneys and adrenals in PET CT look normal. Hence, we move ahead with EBUS TBNA. And EBUS TBNA, the rows showed reactive lymph nodes, but the histopathological examination revealed that it was a granulomatous inflammation without any necrosis. So as a part of further workup, we did serum ACE and serum calcium, which was normal. Mando was done, which was found to be 29 millimeter. It's a final diagnosis of disseminated tuberculosis with lymphadenitis and paravertebral lesion. Hyperuremic hyperaldosteronism was made. So treatment, we initiated her on anti-tubercular medication, and she was sent home with 4 antihypertensive medications. We did call her for a follow-up after 2 months. She was clinically much better. Weight was 49.5 kgs from 46 kgs at the time of admission. From 4 antihypertensive medication, we were able to taper to 2 antihypertensive medication. Plan was to follow up with PET CT after 5 months. So review of literature, TB and uncontrolled hypertension, they are explained 3 mechanisms. So one was a renin secretion, which is increased in patients with renal tuberculosis, might be due to chronic inflammation, which is triggered by a complex cascade, which included heat shock proteins, or a lymph node causing a mechanical compression on the renal artery might be causing secondary hypertension. So probable reason for hypertension in present case would be a hyperuremic hyperaldosteronism. The most probable explanation would be a paravertebral mass, probably lymph nodal mass compressing on renal artery and causing hypertension. PET CT, we were planning to do a PET CT after 5 months, and whether there is a resolution of paravertebral lesion will cause a resolution of hypertension, time will only have to tell, sir. So take home message, secondary hypertension is a medical emergency and needs detailed workup. TB or lymphoid lesion compressing the renal artery, though rare, should be kept in mind as DD. EBUS TBNA, being least invasive and safe procedure for evaluation of mediastinal lymph node adenopathy can be done. So if you think about rare possibilities, you will only be rarely correct. But very common disease can have a very rare presentation. Thank you.
Very difficult case, well worked up. As a general medicine person, whenever somebody comes with benign intracranial hypertension, I can imagine a female patient who is morbidly obese. What was the body mass index of this patient at the time of presentation?
Sir, she was undernourished actually.
And actually these patients are very obese, and commonly they have obstructive sleep apnea, which can explain secondary hypertension. Okay. One of the common causes of resistant hypertension in the medical wards is obstructive sleep apnea, unrecognized. So that was what was coming to my mind when you presented this case. Second thing is, one possibility you mentioned was tuberculosis of the kidney. Tuberculosis of the kidney is diagnosed when we demonstrate AFP urine culture, or by doing caseating granuloma on histopathology. Those things were not there.
No, sir. Yes.
So tuberculosis of the kidney is not a real possibility.
Yes, sir.
Well presented.
Thank you, sir.
Very good case. But I am still doubtful about the tuberculosis. You don't have any definite diagnosis, isn't it? Definite diagnosis. Only
Sir, Mando with strongly positive with symptoms.
postgraduates respiratory medicine don't say Mando is positive, so I diagnose tuberculosis. Don't say that.
Latent tuberculosis.
Because nowadays there is no value for that test because there are so many. Did you send this EBUS biopsy specimen for AFB culture?
Yes, sir. It was negative, sir.
It was negative. So we see a lot of cases like this, mediastinal lymphadenopathy. Do the EBUS, take biopsy, core biopsy, not FNAC. Actually, it is core tissue we are getting. We send it for AFB smear, AFB culture.
Yes, sir.
If it is a case-eating granuloma, definitely we can put on ATT. But if it is not a case-eating granuloma like this case, there is a question of whether it is sarcoidosis or tuberculosis.
Yes,
so we wait for AFB culture. Yes. Sometimes we put on empirical ATT and wait for AFB culture. If it is negative, stop it and consider it sarcoidosis.
Yes,
here the problem is mainly not mediastinal lesion, it is the malignant hypertension which is the issue here,
yes,
isn't it?
Yes, sir.
And I don't believe that this is renovascular hypertension because
no, sir.
only one-sided lesion, it will not produce that. And parenchyma, renal parenchyma is not that much affected
yes,
also.
Sir. Yes, sir.
So there is some other issue, some endocrinal issue maybe there, or either the lesion near the kidney may be inducing some endocrinal issue like what you said, pheochromocytoma or Conn syndrome like that, which can produce hypertension like this. Is a serious issue. Malignant hypertension in such a young individual is a very serious issue. And tuberculosis as a cause of hypertension, I don't even now I cannot get convinced about that particular presentation. Any questions from the audience?
Anyway, you have done EBUS in this case, right?
Yes, sir. Yes, sir.
Can you reach left adrenal gland by an EBUS? If you can reach, how? This patient was having a soft tissue lesion on the left adrenal gland.
Paravertebral area, sir. Adrenals were normal, sir.
PET-CT was showing soft
normal
tissue lesion.
kidneys and
pararenal, yeah.
Vertebral.
Can you reach left adrenal with your EBUS? That's what I want to ask, whether he knows about that. Can you reach with EBUS?
No, sir.
Yeah, you can use that EBUS into esophagus. You call it as EUSB. And you can do EUSB FNA from this left adrenal gland near lesion.
Okay, sir.
This is very easy for gastroenterology.
Okay.
Take biopsy near the pancreas, near the kidney, near the adrenal. They do it through EUS. So very easy. Very easy for them, not for us. Okay. And but we have EBUS. Since there is mediastinal lymph node, we can reach there. But we should take enough tissue and send for all investigations, especially a case like this where there is a doubt regarding whether it is case-eating granuloma or non-case-eating granuloma like that. Okay, thank you.
You told what is the final diagnosis you have made? Renal arteries compression causing malignant hypertension.
Yes, sir. That is.
Have you shown it in the CT? Is there any evidence that it is compressing the renal vessels? It is suprarenal actually, is it? Just above the kidney.
Paravertebral. Yes, sir.
So how can you say that it is compressing the renal artery, causing all these things?
There is no definite.
So has the patient responded to the?
Yes, ATT, sir. Yes, sir. She has gained weight. Clinically, she is much better, and also from 4 antihypertensive medications, we are able to taper to 2 antihypertensives. So within a span of 2 months.
But from the CT, it is not very obvious that it is compressing the renal vessels and causing the
hypertension.
As sir clearly said. Another thing that you said the response to anti-tuberculosis treatment. Even in sarcoidosis, you may have some apparent response to treatment. Yes.
No, sir.
Another thing, you said the decrease in the number of antihypertensives. That too, obviously with the lifestyle modifications, when a patient is diagnosed with hypertension, lifestyle modification, everything. So it could be. There is no objective evidence to say that it is improved. Anyway, we have to wait.
Okay,
Anyway, good case. Thank you.
Thank you, sir. Thank you, sir.
We could have taken a biopsy, CT-gated biopsy from
Yeah,
that lesion, isn't it?
But, sir,
That's a good investigation.
Hemodynamically, she was not that stable. Yes, sir. Yes, sir. Thank you, sir.
With that, we have come to the end of our first set of case presentations for the day. Moving on, we have our inauguration ceremony. All occasions are incomplete without invoking the blessings of the Almighty. Please rise for the prayer.
तुषारहार धवला या शुभ्रवस्त्रान्विता या वीणां वरदण्डमण्डितकरा या श्वेत पद्मासना या ब्रह्माच्युत शङ्कर प्रभृतिभिर्देवैः सदा पूजिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा।
Please be seated. Next, I invite Dr. Thomas Vadakin, President, APT, to welcome the gathering.
Good morning, everyone. We are starting with our inauguration ceremony. We request all our guests to kindly occupy the stage. I invite Dr. Shahjahan PS, the APCCM President, onto the dais. Let me welcome Dr. Kuriyanuman sir, the President-elect of APCCM, onto the dais. I request Dr. Thomas Vadakan, President APT, to kindly occupy the stage, and Dr. Jamshir, Secretary of APT, to kindly occupy the stage. May I also invite Dr. Davis Paul Sri, the Scientific Committee Chair, onto the dais. Thank you. The chief guest of today is Dr. Pratap Somnath sir, who is the principal of Government Medical College, Thrissur. He'll be inaugurating and giving the chief guest address through online. So it's our pleasure in inviting you for the ceremony, sir. Thank you. Let me welcome Dr. Thomas Vadakan, President APT, for the welcome address.
Good morning, one and all. It's my pleasure to welcome you all to Thrissur once again. We have two conferences in the last year, 2021, Aptcon 2021 and Palmacon 2021. Now this new year we start with Aptcon 2022, and I'm very privileged and honored to welcome you all. I'm very sorry that we could do it only in hybrid mode because of the present COVID crisis, but still we could do in a better way in the hybrid platform. So today we have our chief guest, the principal of Government Medical College, Thrissur, and he is with us in online platform. On behalf of team Aptcon, I welcome Dr. Pratap Somnath, principal of GMC Thrissur, to our inauguration ceremony.
Thank you.
Next, our chief guest is Dr. Shahjahan, he is the president of Academy of Pulmonary and Critical Care Medicine, and he is a popular figure who is very active in fighting against the environmental pollution and lung diseases associated with that. I take this opportunity to congratulate him and welcome him to our stage. Dr. Kurian Uman is our President-elect of Academy of Pulmonary and Critical Care Medicine, and he is with us to bless our occasion. On behalf of Team Pulmocon, Team APT, I invite him to our dais. Dr. Davis Paul sir was the key in conducting our APTCon 2022. He was the chair of scientific committee, and he was there to judge the initial screening of case reports which we got, and he did his work well, and it's my pleasure to welcome sir to the dais. Dr. Jamshir, Secretary of APT and APTCon 2022, it's my pleasure to welcome him to the dais. In the audience, I can see many of my teachers, great teachers, Professor T.P. Anthony sir, Dr. C. Ravindran, Kurian Thomas sir, and various senior faculties of Association of Pulmonologists, Dr. Thomas George from Government Medical College, Dr. Ennis Davis, Dr. Krishna Kumar, and I think it's very difficult for me to mention all your name. I welcome you all sincerely to this program. And there are many doctors, delegates, members of APCCM online participating in our program. I sincerely welcome them all. And a lot of postgraduates are also participating in our conference. And I sincerely welcome you all once again, and thank you.
Thank you, sir. Next, for the presidential address, I invite Dr. Shahjahan PS, President, APCCM.
Organizing Chairman, my dear friend Dr. Thomas Vadakan, Secretary Dr. Jamshir, Scientific Committee Chairman, Professor Dr. Davis Paul, President-elect of APCCM, Dr. Kurian Uman, luminaries in the audience as well as online, my dear colleagues and friends. At the outset, I congratulate Team APT for this wonderful conference. Even during these troubled times, they are conducting it regularly, either offline, online, or hybrid. I should say only APT is conducting these kind of activities at this troubled time. Of course, almost all our chess clubs are very active with the dynamic programs, but for the last 2 years, somehow this kind of activities set back. But still, thank you APT. Even our Pulmocon 2021, which was scheduled earlier in Kannur in a physical mode, well before the COVID pandemic emerged, we find it very difficult to conduct. It goes on like this. But at last, Team APT volunteered to conduct this program in the last October and conducted in a marvelous way in this hall itself. And thank you, APT, for this wonderful gesture from you. I'm really happy to be here because this program is regularly conducting, and also in memory of late professors Dr. K. Nadarajayar sir, and also our own president, Dr. Mohan sir. And I congratulate Ravindra sir and Kurian Thomas sir for receiving the awards in behalf of them. So, on behalf of APCCM and myself, and also Dr. B. Jayaprakash, he could not come to this conference. He was planning to come, so at that last moment he could not come. And many delegates wanted to come in physical, but what happens is that because of this epidemic, many people turned positive or either symptomatic or become primary contact, so they could not come. So on behalf of the office bearers of APCCM, senior members of APCCM, I congratulate APT for once again for this wonderful meeting. Please do continue your good work. All the best for this conference. Thank you.
Thank you, sir. Next, we have the lamp lighting ceremony, and I invite Dr. Shahjahan PS, Dr. Kurian Umman, Dr. Thomas Vadakan, Dr. Davis Paul, Dr. A.K. Jamsheed for the same. Next, we have the Chief Guest Address by Dr. Pradap Sobnath, Principal, Government Medical College, Thrissur. He'll be joining us online for this function.
Good morning, all. Can you hear me? Am I audible? Hello?
Yes, sir, please.
Okay. So, dignitaries and friends, a very warm good morning to all of you. Thank you, organizers, for the. In fact, we should first of all laud the efforts of the Association of Pulmonologists of Thrissur for having such a conference today, especially as Dr. Shahjahan said, during troubled times. Because if you look at all other departments, several departments have backed out from the conferences, and you were so brave and you put your foot down and started fighting COVID head on. Probably because you are all pulmonologists, you feel more confident than all the departments. Anyway, that's a compliment. Now, the point is, we don't want the corona has already done spoil sport over the last 2 years. So we don't want any more of corona breaking into our normal routine, because if this is going to continue, we'll be creating corona doctors and corona graduates. And corona is changing colors every other day. So if corona is becoming smart, we have to become smarter. And so at least if you can't have a physical conference, even a hybrid conference is okay. And when I asked a theme to Dr. Murali and Dr. Thomas, said that they are not insisting on didactic lectures, which is something very great, because with the online lectures, all people are all fed up listening to online programs. So case discussion, especially challenging cases discussion, along with the faculties, is something very remarkable. That's an excellent idea. It has to be copied by other departments as well. I'll definitely talk to the other department, stimulate them also to have such similar conferences. Because over the years, we have started seeing that undergraduates and postgraduates, they are becoming, they are turning into bankrupt. They have lost interest because everywhere where they keep, and non-COVID cases are on the, they are not exposed to the because of restrictions. It's a good thing that consultants have come forward to keep the flame of it burning and then come up with all such rare cases, which is the highlight or landmark of medical college institution. So let us take Corona on stride. It's just like during the, we'll have the sanitizer and social as reasonable as possible. And let us continue the efforts to improve the postgraduate and also have better clinical correlation rare cases. So words I wish all success for friends, and thank you for this for. Thank you all.
Thank you, sir, for joining us today morning and sparing your valuable time. Next, I invite Dr. Davis Paul C., Vice President, APCCM, for the felicitation of the gathering.
Good morning. The President of APCCM, Dr. Shahjahan, the Chief Guest of the day, Dr. Pratap, Principal, Government Medical College, Thrissur, the President-elect of APCCM, Dr. Eminent, the President of APT, Dr. Thomas Vadakan, and Secretary of APCCM, Dr. Jamshir, the respected judges, Dr. T.P. Antony and Dr. C. Ravindran, the respected teachers, colleagues, and dear friends. So, anybody can swim, but very few people can swim in a sea. That is what Dr. Thomas Vadakan and Dr. Jamshir has done today. So all odds are against us, but they have decided to go on with this conference, a conference with a little difference, where a day is dedicated only for discussing special and interesting cases. This is an initiation of APT few years back, and it is still continuing. And the interest in which they have taken it, this type of conference, I really appreciate them. So we should include, my opinion is we should include not only the successful cases, but also failed cases, because very often we may not be able to come to a diagnosis in all cases. There are very occasions where we failed miserably, and that also has to be highlighted. So I think we will include such cases also, and we will discuss what are the other people's opinion regarding that. That will make the things much more interesting. And I request APCCM to conduct this type of conferences in future also under the leadership of APCCM. And they can also include the research paper publication, the research studies, which APCCM should take up and dedicate one day for discussion of this type of research papers, because we are giving more importance to research now. And the research is done most often just for filling up this thesis. That has to change, more research, because in COVID we have done a lot of papers, but none of Indian papers has got much acceptance. We are all following what the others are doing. We are not doing our own studies, which is of some value. So it has to change. So we are going to be more important to research also. So the conference is dedicated, instead of didactic lectures, we change into this type of things, which will make things much more interesting to those who attend that. So anyhow, this is a special conference. I think this will continue like this. I wish all success for this conference. Thank you very much.
Thank you, sir. Next, I invite Dr. Kurian Newman, President-elect, for the felicitation of the gathering.
APCCM President Dr. P.S. Shahjahan, President APT Dr. Thomas Wadakan, the Chief Guest Dr. Pradap Somnath, Principal, Eminent Medical College, Thrissur, Dr. David Spolsa, Dr. Shamshir. I am very happy to be here at Thrissur because for the past few years you are conducting regular meetings and during these COVID seasons, especially a grand annual conference was conducted here. It was very, very great success, and also the very particular you are conducting the Memorial Oration Award. I think no other chess club are doing this Oration Award. You are doing for the past few years, Nardaya Oration Award, and also Dr. N. Mohan Oration Award. We are very glad to be here for this meeting, and all the best for the meeting and for the APT. Thank you. Thank you very much.
Thank you, sir. To conclude our inaugural session, I invite Dr. A.K. Jamshed.
I invite Dr. Shahjahan sir and Thomas Wadakan sir for officially unveiling the calendar of APT. We have our calendar APT 2022. I request all the chief guests, all the guests to kindly.
I would like to invite Dr. Shahjahan sir to give memento to Professor C. Ravindran for the This is for the judging the case reports, and thank you for coming, and this is a appreciation from APT. Let me invite Professor T.P. Anthony sir to receive memento for judging the case reports. Thank you, sir.
Next, I invite Dr. A.K. Jamshed, Secretary, APT, for the vote of thanks.
Warm good morning to each and every one of you who are attending the conference physically and who are online. It's a great pleasure and honored to have been asked to offer a word of thanks on the occasion of Association of Pulmonologists Thrissur Annual Meet APTCon 2022. First of all, on behalf of APT, I would like to extend my sincere gratitude to APCCM President Dr. Shahjahan sir, President-elect Dr. Kurian Newman sir, Vice President Dr. Davis Paul sir, and other office bearers of APCCM for their enormous support given to this conference in a unique way as in previous years. I wholeheartedly thank our honorable and respected chief guest, Dr. Pradap Somnath sir, Principal of Government Medical College Thrissur, for being a part of this conference in the inaugural ceremony despite of his busy schedule. I'm very hearty gratitude to Dr. C. Ravindra sir for outstanding Nataraj Iyer sir's oration, and Dr. Kurian Thomas sir for remarkable Dr. Mohan sir oration. I want to extend my generous thanks to our respected judges who have done an Herculean task to get the gem out of the rest of the presenters. I take this occurrence to wholeheartedly thank the mentors and HODs of the medical colleges and other institutions who have helped us a lot, sharing their precious abstracts for the case presentations. And we have received more than 20 abstracts. And I thank all the residents who have sent their abstract to support this conference. I take this opportunity to thank all our scientific committee members, headed by Dr. Davis Paul sir, along with Dr. Thomas Joe sir, who is the HOD of Pulmonary Medicine Department, Government Medical College, Thrissur, Dr. Rennis Davis sir, HOD of Pulmonary Medicine Department, Amila Institute, Dr. Supriya Diodi ma'am, HOD of the Respiratory Medicine Department, Jubilee Mission Medical College. Now, I must remark a proficient sense of gratefulness to our APT's past president, Dr. Judo Vachaparamil sir, past secretary, Dr. Unni sir, and all other APT members who have supported directly and indirectly to make this conference a great success. I should not forget to mention Mr. Divin, who have supported us tirelessly for the smooth conduct of this conference. And I thank all the pharmaceutical companies who have sponsored for this conference. Last but not least, I thank Aaron Moss's team for their audiovisual support, and our host, Das Continental Hotel, for their great hospitality. And thank you very much for making this conference grand success to everyone. Thank you.
Thank you, sir. With that, we have come to the end of our inaugural session. We shall have a short tea break and start with our next session, which is the APT orations at around 10:40. Next up, we have our APT orations. First, we have Dr. K. Nataraja Iyer Memorial Oration. And I invite Dr. Thomas Vadakan to invite Dr. C. Ravindran to the gathering. പൊന്നാട അണിയിക്കാനും മൊമെന്റോ നൽകാനുമായി ഡോക്ടർ തോമസ് വടക്കനെ ക്ഷണിക്കുന്നു.
It's my great pleasure to remember Dr. Nataraj Iyer sir. Actually, sir was my teacher when I was third year MB medical student in Government Medical College, Thrissur. He's the one taught me the basic lessons of respiratory system. I still remember the older version of lung volume measuring in a revolving drum, and he showed me this, and at least 2 weeks posting was there, and every day he used to engage up to 12 o'clock, and he offered a tea also end of the posting, and it was a good old memories about the great teacher. Later I understood he was a teacher and mentor for many of the postgraduates, and sir was there in the founder of APT, and I was also were there in that meeting, and a lot of memories about him, and he always used to make jokes when I talked to him. And today we are remembering him in this oration, and this oration is done by another great person, Dr. C. Ravindran sir. Sir was previous principal of Calicut Medical College. Currently sir is working in Baby Memorial Hospital, and he is the president of Kerala chapter of ICS, and he has many publications, more than 75 publications, and many chapters in various textbooks, and a great pulmonologist and academician. And I humbly invite Professor Ravindran sir for Dr. Nadaraj Iyer sir memorial oration.
ഡോക്ടർ തോമസ് വടക്കൻ ഇപ്പോൾ ഡോക്ടർ സി രവീന്ദ്രനെ പൊന്നാട അണിയിക്കുന്നതാണ്.
Respected senior members of the profession, dear delegates, and the office bearers of APT, I'm very much thankful to APT, especially Dr. Thomas, for inviting me to deliver this oration on the name of Professor Dr. K. Nadaraj Iyer, Professor of and Head of the Department of Pulmonary Medicine in Trichur Medical College. If I say something about Dr. Nadaraj Iyer in this audience, that is Trichurians, it will not be apt, because he is always a man from Trichur. After his tenure in Trivandrum, he came to Trichur, and till his demise, he was in Trichur. And many of our senior teachers, present teachers, are his students. So I want to narrate a separate story for you, because I joined diploma DTCD in 2003 and did the class on March 1. And Dr. N.V. Warrior, Dr. K.N. Pilla, and Dr. K.P. Govindan were the teachers at that time. I was in the second batch. In 5 days, we had a morning and evening class by Dr. N.V. Warrior. And then on 6th, both N.V. Warrior and Dr. Govindan left to Iran after taking 5 years loss of pay leave. Then left was Dr. K.N. Pilla, who was assistant professor at that time. And being a postgraduate teacher, government posted Dr. Nadaraj Iyer to Calicut. So we were all glad to welcome Dr. Nadaraj Iyer. At that point of time, the origin of Trichur Medical College came, and they decided to take Mulanganathukavu Sanatorium for Trichur Medical College. And somebody went to the High Court, got an injection, saying that TB patients will not be treated properly if it is converted to medical college. Then government has no option. They cancelled the posting of Dr. Nadaraj Iyer to Calicut and posted him at Trivandrum. And that was given in the High Court, saying that a senior member was posted at Trichur to look after chest patients. So that settled the issue. So I could not be a student under him. He came for exam, but I was not a student under him. But I always remember him for his witty comments and knowledgeable talks. And many times I visited him at Trichur. So my pranamam to our great teacher. Today, my topic is slightly different. Children with respiratory diseases, who can treat them well, is the caption of my oration. Why I have taken this topic is, we all treat respiratory diseases in adults, but there are a lot of patients, children, present with respiratory diseases who are being treated by pediatrician probably, and few patients will come to us also. And in my practice, usually 20 to 25% of my patients are children. So I thought that there should be some change in our approach when we get pediatric patients. It is easy to treat adult patients, but when we get pediatric patients, especially small children, there should be a slight change in our outlook and way of diagnostic modalities as well as treatment modalities. So my talk will not be on respiratory diseases in children. My talk will be mainly on my perception on respiratory disease children whom we can treat. We can means adult pulmonologist. This is the institution where I work now. Recently, I joined Baby Memorial Hospital. And why I selected this particular topic, there are two reasons. And I was working in DMMs in Wayanad. All the children with respiratory diseases were sent for consultation to us, including NICU patients. Even small babies were sent for consultation when they have a respiratory disease. So actually we have to see such small kids. Then we'll have to prepare for that. Many things are unknown to us, or we are not familiar with many diseases. So we'll have to prepare for that. So that way it changed my outlook a lot better. When we were in Calicut Medical, we don't get pediatric patients for consultation because it is an entirely different scenario in Calicut Medical. But why not? Every case was referred to us, and I had to visit NICU also for giving opinion in that. So this is the paper I have published on the cases in neonatology, premature children born during 1 year in DMVMs and admitted in NICU and treated properly. And you can see that the mortality in that premature infants is 4.83% only, because there is a combined approach to management, diagnosis and management of these children. So that way, the outcome improved a lot. So that way, we can all do that to an extent. We need not pull the patient from pediatrician, but we can give opinion to them. Sometimes we are the best person to give opinion to that. And second reason is we had a professor in Calicut Medical College in orthopedics, and he is working in a private hospital now. He started pediatric orthopedics and fellowship in pediatric orthopedics. And I discussed with him, and he said that because pediatric orthopedic cases in pediatrics are neglected, his sister as a school child died because of an ortho problem. And when he became doctor, he decided that he will take ortho and then he will practice pediatric orthopedics. So now there is a fellowship under him. He trains people for pediatrics. So that way also we can also change our practice. Orientation towards pediatric patient can be done to a large extent. So who is treating these patients now? There is no dedicated pediatric pulmonologist, unlike in specialty like cardiology, neurology, and nephrology. They have pediatric neurologists, pediatric cardiologists, pediatric nephrologists. Specialty is coming up. So we can have a pediatric pulmonology section also. And these cases are mostly treated by pediatricians. There are pediatricians practicing pulmonary medicine alone. There are few pediatricians who practice pulmonary medicine alone, but their number is very few. So my question is, can we, the adult pulmonologists, treat them well? And answer is possible with a little bit of interest and training. We need some hard reading about pediatric cases because they are not always like adults. Diagnosis may be entirely different for us. Same radiological shadow diagnosis may be entirely different in a child when compared to an adult. And we need some training and some interest also, otherwise we cannot get trained. And I think the DM syllabus was prepared by me for Kerala University Health Science, and I have added pediatric pulmonology as a topic in that. When you go through the syllabus, you can see that pediatric pulmonology is there, and there is no dedicated book, so I put my book as the reference there. You can see the pediatric respiratory illness, which was written by me and my colleagues in Calicut Medical College. We all together prepared this book. And before treating these children, we should know the child's physiology, child's psychology, disease pattern. The disease pattern is entirely different, not like our COPD, asthma like that. Even asthma in adult and children are slightly different. So we'll have to know the disease pattern. There are so many congenital anomalies in children, so that also we will have to take care of. And even if we take an interstitial lung disease, the adult interstitial lung disease and child interstitial lung disease costs are entirely different. So we'll have to look at that particular point. And the pharmacodynamics, how we prescribe medicines, how much we prescribe medicines, what are the side effects, entirely different. So we'll have to study that. But remember that never consider child as a miniature adult and treat. This is one case. Recently, this boy came to me, a 4-year-old boy undergoing rehabilitation for attention deficit disorder. He presented with cough, wheeze for the last 15 days and had fever for the initial 2 days. This child had similar attack 2 years back and was treated and cured at that time. There is no family history of asthma or allergic rhinitis. This child was treated as asthma with inhaled corticosteroid and bronchodilators. And they didn't get any response. That is why they came to me. So what is the diagnosis? The chest X-ray seen by the first consultant, it was written as normal. This is that X-ray. Is it normal? It is not normal. So that is why we interpret the X-ray of a child. So we'll have to look at miniature shadows and give some differential diagnosis for that particular shadows also. So this child, the second episode of cough and wheezing starting as fever is the diagnosis here. What are the differential diagnoses? We can consider bronchiolitis here because first episode was before 2 years. The first diagnosis is bronchiolitis. We can consider bronchial asthma because there are 2 episodes now. Bronchial asthma we can consider. This can be bronchopneumonia because radiology shows multiple alveolar shadows in both midzones, so bronchopneumonia. Or it can still be bronchiectasis. Congenital bronchiectasis can present like this. These are the 4 important differential diagnoses when we consider this particular child with this X-ray. So we'll have to look at what is the actual problem for this child. Less than 2 years, always consider bronchiolitis as the first diagnosis. Suppose the patient presents with fever, cough, and breathlessness or wheezing before 2 years or even before 3 years, consider bronchiolitis as the diagnosis. And 2 to 5 years, there may be overlap between bronchiolitis and asthma. And more than 5 years, asthma becomes the first choice of diagnosis. And coexisting bronchopneumonia like this child is possible. That can be possible in bronchiolitis, bronchial asthma, and bronchiectasis is a cause for recurrent cough and wheeze in children. So all these possibilities are still there in this particular patient. So what is bronchiolitis? This is the term which we are unfamiliar, bronchiolitis. We diagnose respiratory bronchiolitis, sometimes obliteratory bronchiolitis, but pediatric bronchiolitis is an entirely different issue. It is unfamiliar to us. So when a child comes with cough and wheeze, we always put a diagnosis of asthma and treat it as asthma. It is not always asthma. That is the issue. Bronchiolitis is an acute inflammatory injury of the bronchioles that is usually caused by a viral infection. Usually it is respiratory syncytial virus. Bronchiolitis is common cause of illness and hospitalization in infant and young children. This particular child has got bronchiolitis. Bronchiolitis is the first episode of wheezing in a child younger than 12 to 24 months. 2 years, less than 2 years, always bronchiolitis, unless there is typical family history and recurrent wheezing, which is reversible airway obstruction. It is mostly a self-limiting condition and is almost always caused by respiratory syncytial virus. Clinical feature, I need not elaborate all these things. Patient can have wheezing, tachypnea, hypoxemia, all those problems can have. And wheezing illness other than asthma in children younger than 3 years of age have been diagnosed with bronchiolitis. Most cases are mild and clear up. But in certain children, it can persist and even sometimes hospitalization is required. Diagnosis based on the clinical findings, tachypnea will be there, distress will be there, tachypnea will be there, fever, retraction, crackles and wheeze, hypoxemia. And imaging study is mostly not needed, but in cases which do not respond or progresses, we'll have to take an X-ray test, as in this case. Management, as we all know, it is slightly different from asthma. Here, we'll have to maintain hydration, nasal and oral suctioning, intranasal decongestant, corticosteroids are needed, systemic corticosteroid, it will not respond to inhaled corticosteroid, and antibiotic, because secondary infection in a viral infection is more common, and sometimes some center treat with antiviral agents. And we may have to give oxygen, supplemental oxygen, or even severe cases, mechanical ventilation. So what is the importance of bronchiolitis? That is a question here. So if we don't treat this bronchiolitis properly, when the child presents, it can recur. And 1 or 2 or 3 bronchiolitis occurring in a child will definitely lead the child into an asthmatic element. So that will become an asthma later. That is the issue here. So we should identify and treat bronchiolitis then and there so that this child will not suffer from prolonged illness like asthma later. So asthma, we know, is a chronic inflammatory airways, and diagnosis of asthma should be used only after recurrent reversible wheezing episodes. Bronchiolitis is different, asthma is different. And it has been estimated that 50% of children with bronchiolitis have recurrent wheezing, assessed by the parents, or asthma diagnosed by the physician. So recurrent bronchiolitis usually goes to an asthmatic stage in later childhood. So respiratory viral infection predisposes to chronic asthma occur during infancy when immunological mutations maturation has not yet developed fully. It is well established that respiratory syncytial virus bronchiolitis is associated strongly with recurrent wheezing and asthma, at least during the first decade of life. So a child before 2 years getting recurrent bronchiolitis means they will suffer from asthma in the next decade. So this is the mechanism. There will be an interaction between environment, age, and genetics. So there will be a predisposing element. Predisposed individuals, viral or atypical infection is the trigger. Then acute and chronic inflammation. Later it becomes asthma or bronchial hyperreactivity. So you can have a viral infection leading to bronchiolitis because of inflammation, or you can have a viral induced wheeze in these children. So later, if the child is atopic, if there is definite history of allergy in the child or in the family, strong family history, they will go in for asthma. These are all statistics. RSV bronchiolitis in early life study, a prospective cohort of infants hospitalized for RSV bronchiolitis focused on the identification of determinants of post-RSV asthma. And they recently reported asthma-related outcomes in 6 years following the initial bronchiolitis. Another study among 206 children enrolled with severe RSV bronchiolitis during the first year of life. 48% had received a physician diagnosis of asthma by the 7th birthday. So remember that if before 2, if you get bronchiolitis, there is a chance that they will develop asthma in later life. And clinical cause of asthma in children is extremely variable. When compared to adults, it is extremely variable. Some children have early onset beginning in infancy and regress completely. And they are treated early in early life, before 5 or 6, and they regress completely without any evidence of asthma later. Others develop at a later age. That is, if they develop at a later age, 5 to 6 years, a first episode, 5 to 6 years, then they continue to be symptomatic throughout their life and progress to irreversible airflow obstruction later. And knowledge on the natural history of asthma is important for the understanding and predicting the clinical course of different asthmatic phenotypes. So we have different phenotypes in this group. And frequency of wheezing is more up to 11 years of age in these children. Remission is more common in those who had their first episode of wheezing before 5 years. So we should remember that if the child develops asthma before the age of 5 years, remission, complete remission is possible in such child, will not show any evidence of asthma in later childhood or adult life. But if they develop wheezing at a later age, and they don't have any wheezing in the early childhood, but develop in a later age, their wheezing continues, and it continues to the adulthood. So these are the 3 important phenotypes we have: infant wheezers, preschool wheezers, and late childhood wheezers. So we can see that infant wheezers, they will have complete, mostly due to bronchiolitis, they have complete remission. And even 1 to 6 years, there is a chance that they may improve. But late childhood wheeze, they progress with relapses and progress up to adult life. And clinical, another classification is children are classified into never wheezers, transient early wheezers, which you have seen in the previous slide, a late onset wheeze at 6 years, and persistent wheeze. So we can classify children with asthma into these 4 groups. So naturally we can consider these children, what will happen to them later when they grow. That is a very important question before us. So whether to continue treatment throughout life like adult asthma, or whether to stop it at a particular age, we can decide on that type of occurrence of disease. If it is an early onset, before 5 years, they may go for remission. If it is a late onset, after 6 years, they may have persistent recurrent wheeze and persistent wheeze later life. So that is a different type of approach we need to follow in children. Clinical phenotype, episodic wheeze associated viral infection, described as wheezing during discrete time periods, often in association with clinical evidence of viral cold, with absence of wheezing between episodes. Mostly these younger children, we consider this as bronchiolitis. But there is a later childhood, when they get wheezing like that, you look at the multiple trigger factors. It may be due to trigger wheeze, which is similar to asthma. It may progress later. So this is described as wheezing that shows discrete exacerbation, but also have symptoms between episodes. There's another issue in children, atopic march. And many children come to us with a skin lesion earlier, and now with asthma like that. So there is a theory behind that. Atopic march begins as eczema in infancy, followed by allergic rhinitis later, and asthma in adulthood. So naturally there is a progress from atopic dermatitis or eczema to allergic rhinitis and then to asthma. Childhood eczema was significantly associated with new onset asthma in 3 separate life stages. One is pre-adolescence, second is adolescence, third is adult life between 8 to 44 years. And we have a predictive index. When you look at the children, we have a predictive index given for that. There are 3 conditions. One is obligatory, where recurrent episode of wheezing during previous year. That is one obligatory condition which should be there for all cases. Then major criteria, atopic dermatitis, physician diagnosed parental asthma. And minor criteria, peripheral blood eosinophilia, wheezing apart from cold, and physician diagnosed allergic rhinitis. So when you have these points, you can make a positive predictive index if obligatory plus 1 major and 2 minor criteria are there. Definitely it is asthma predictive index positive. Then the question is, these children up to 12 years, we consider 12 children. Now we consider up to 18 years as children. So we always consider 18 years, up to 18 years as children. So there is a stage where there is adolescence and young adults. So these children will grow to adolescents and young adults. What will happen when they grow to that stage? Adolescents and young adults form a large group of patients with asthma. Medical care in this group is complicated by biological, psychological and social changes in this age group. We know that because they follow the peer group pressure rather than parental pressure. So there are certain conditions like biological, psychological and social factors which will decide on their diagnosis, treatment and progress of disease. So these adolescent and young adults gain increasing autonomy. They also have to become more socially and financially independent, while their primary relationships switch from family to peer-based interactions. So they cannot cut classes even if there is asthma because their group is like that. These changes may continue up to 25 years age. So when we treat this group of children, we have to consider all these factors. Just saying that you take an inhaler or a nasal spray will not be sufficient at that particular point of time. We will have to convince the student or the child or the adolescent about what you are going to do and what is the importance, all these things, and not give instruction to the parent and tell them to force your student to take this. That is the difference when we manage adolescents and young adults. This is the new book we have released on clinical allergy and asthma management in adolescents and young adults, which is available in Amazon. Third diagnosis is bronchiectasis. We all see bronchiectasis. A lot of bronchiectasis cases we manage. In children, what is the difference? We have to basically divide it into cystic fibrosis bronchiectasis, non-cystic fibrosis bronchiectasis. Even though we consider that cystic fibrosis bronchiectasis is rare in our area, it is not like that. If you look at it, you will find cystic fibrosis around us. So most of the cases are managed as bronchiectasis. They will not be the complete cystic fibrosis which we read in textbook. It may be an incomplete or partial cystic fibrosis. We know there are a lot of mutations, and if certain mutations, they grow as incomplete cystic fibrosis. So it is our duty to pick up those cases because treatment is entirely different. I'm not going to the theory of cystic fibrosis. These are all known to you. This is a 6-year-old girl who presented to me with 14 X-rays. Every X-ray shows different shadows. Collapse in the right upper lobe, hilar shadows, mucus plugging, nodular shadows, all those things. Every X-ray is different. 6-year-old girl who there is failure to thrive. There is wheezing is the symptom. Main symptom is wheezing. So that girl is not a simple respiratory disease. Cannot be diagnosed as collapse, cannot be diagnosed as pneumonia, cannot be diagnosed as asthma. So entirely different. Something is there underlying. So when you look at the X-rays and when we take the CT, we see that this is cystic fibrosis. So management is entirely different in such. This is a CT. You can see the mucus plugging left side. There is mucus plugging, multiple nodular shadows, bronchiectasis change in the middle lobe. All these findings are there in this child, and she was managed as cystic fibrosis. So you'll have to give prophylaxis for infection and all. One or more clinical features of cystic fibrosis plus identification of 2 CF mutations. There are so many CF mutations, so if we can identify 2 CF mutations among that, you can make a diagnosis. Or a positive pilocarpine iontophoresis test or an abnormal nasal transepithelial potential difference, which are available now. Management, there are so many management. Mainly we'll have to look at bronchodilation, mucolytic agents, and prevention of secondary infection, especially Pseudomonas infection prevention. That is the most important one, which improves the longevity of these children. Now there are lung transplantation, gene therapy, all these things are there, which are not that easy in our setup. So we'll have to look at the patient's perspective when we manage these children, because entirely different. Their quality of life is different, their growth is different, their symptomatology is different. So everything is different. So we'll have to look at the child in a different perspective and manage like that only. This is a 7-year-old girl, years back, presented to Calicut Medical College with bilateral pneumothorax. You can see the bilateral pneumothorax, consolidation, cystic changes. And when we took a detailed history, the 5-year-old sibling, another girl, also has similar symptoms and similar radiological picture. And both of them were sent to Chennai for diagnosis. This was years back for diagnosis, and they have done the mutation studies and diagnosed as cystic fibrosis. We lost both children due to severe infection. Then the non-CF bronchiectasis. Again, we have these patients in our midst, but when they are children with bronchiectasis, they have so many social issues like going to school, cough, expectoration, purulent sputum, frequent infection, hospitalization, all those problems are there. So quality of life is very poor in these children. So now it is seen that if you give azithromycin prophylaxis, long-term azithromycin in these children, their progression can be arrested to an extent, not completely, but to an extent. This 16-year-old boy was treated as asthma for so many years. So when we investigated, you can see that these bilateral shadows, their CT shows cystic shadows, mucus plugging, all these things are. So we have to address to these pathophysiology of the child, as well as to the child's age also to consider, because he is going to the +1 from SSLC. So we'll have to look at those things also. Otherwise, he is very much depressed. So we'll have to take him into that perspective and manage. Otherwise, very difficult to bring them to the normal mood. And there are a lot of other cystic diseases in this in our group. And most of when you read CT thorax, most of them are put as bronchiectasis. We also sign under that, bronchiectasis. And many of these bronchiectasis are not bronchiectasis at all. There are entirely different group of conditions which we should read. We should be able to read CT thorax. We should be able to identify cases, such cases. It cannot be managed as simply as bronchiectasis. And the CT, sometimes many center will give you good report, but many radiologists put it as bronchiectasis. So this is a fetal ultrasound, and this is a 20 weeks gestation, staff in the hospital. She's a late pregnancy, and ultrasound abdomen showed cyst in the lung. You can see the cyst in the lung. And this, nobody wanted to give a definite opinion regarding what to do next. And gynecologist said that we will wait and see, like that. Then she came to know that we had few case reports on this, and family came to me saying this is the situation. Then I asked her, by that time it was 22 weeks, I asked her to go to another anomaly scan specialist. And they correctly gave the diagnosis as congenital pulmonary airway malformation type 3 involving the right lung. So what is the future of that child? Either the child will be delivered as dead baby, or the child will be born live and will progress as a disease. And probably somebody will diagnose bronchiectasis and treat. That is the issue. So at this particular point of time, it is termination. And by that time it was 24 weeks, nobody wanted to terminate. Finally we managed to advise somebody to meet somebody and terminate it. Otherwise, this is going to be a real problem for that particular family, having a child like this, and later this can go for malignancy also. Congenital pulmonary airway malformation is well known to develop malignancy at a later life. So certain few cysts, 1 or 2 cysts we can ignore, but when there is lot of cysts like that, it is better that we advise. So we advised, so I am the person advised. I advised her to terminate this pregnancy, so whatever cost is there. So that was done. Otherwise it is going to be a big issue. This is another child. You may see the X-ray. There will be a temptation to believe that there is something on the left side. But actually, it is on the right side. Right side, large enlarging cyst, compressing the mediastinum and pushing it to the opposite side. CT, you can see the whole mediastinum is shifted to the left. Left lung is normal, but it is almost collapsed. And there are multiple cysts. You can see the large cyst towards the periphery, surrounded by small cysts. This is a congenital pulmonary airway malformation. This is type 1 by appearance, but the whole lung is involved. So that child cannot survive, because unless we remove that pressure, opposite lung will not work. That is why this is operated in Calicut, and see the cyst being removed in that. This is a hypoplastic lung. Aplasia or hypoplasia I cannot say, but see the opposite lung is completely normal, hyperinflated, but the right lung is not developed. It has developed into multiple cysts. Probably we will get a diagnosis of bronchiectasis. It is not bronchiectasis. It is a hypoplastic lung. The best way is to remove that. Otherwise, as the child grows, there may be a lot of complications with secondary infections, and it will affect the opposite normal lung also. So we'll have to remove that particular lung. Then lastly, pneumonia. Pneumonia is the other important differential diagnosis which we have given initially. Pneumonia is the leading cause of mortality among children. Even now, in this antibiotic era, we have children dying of pneumonia. There are many challenges that need to be addressed to reduce the impact of disease. Number one is malnutrition, inadequate access to healthcare, and lack of immunization are significant factors. Measures to decrease and eliminate child death should focus on controlling and managing infectious causes. Burden of pneumonia can be diminished using preventive measures ranging from the simplest infection control methods like hand washing, vaccination against infections, limiting exposure to infectious cases, and preventing exposure to tobacco. So we know that in other countries, all the children are mandatorily given influenza vaccination and pneumococcal vaccination. So we are not following that, even though it is included now. Even it is not strictly followed. followed in our country. So we, at this corona era at least, we have to think about that, and all the children should be given preventive vaccination to prevent development of pneumonia and death due to that. See this cause of death below 5 pneumonia, 15% cause of death below 5 children are due to pneumonia. And correct diagnosis is the most important, making the distinction between acute VC bronchial, because these children respiratory, whether it is bronchiolitis, bronchial asthma, bronchiectasis or pneumonia, the first presentation in the form of VC. So bronchiolitis, VC bronchiolitis, asthma and pneumonia is that there are groups of children who do not need antibiotics. So certain people are viral bronchiolitis or asthma who do not need any antibiotic, but certain group of children need antibiotic because they are having pneumonia. So we have to decide who needs antibiotic, who don't need antibiotic. Implication of not making this distinction is the overuse of antibiotic and the under-treatment of asthma. So that way we have to differentiate. This is one chapter written along with my colleague, friend, who was a pediatrician and family medicine specialist in USA. He has written this chapter in the World Clinic on pneumonia in children. These are all known to you because when we consider the cause of pneumonia, it is entirely different in neonates, young children, as well as older children. So organisms are entirely different. Even when we consider virus, we see the viri are different in different age groups. So we should know what actually is that. When you take streptococcus, we know that what type of streptococcus produces pneumonia in children, not the streptococcus which produces pneumonia in adults. So we know that. So similarly, staphylococcus is very common in infants and young children as well as adolescents. So we'll have to know these things, then only we can manage. And the curve index or pneumonia severity index is not applicable in children. So we can just follow the respiratory rate. Less than 2 months, more than 60 breath severity. 2 to 12 months, more than 50 shows severity, like that. These are 2 pictures which I have taken children below right lower lobe pneumonia and right upper lobe pneumonia. This is a 30-year-old infant admitted in the NICU with these shadows, and they called us for consultation. You can see that multiple shadows are there, just like looking like a interstitial lung disease. And in children or infants, interstitial lung disease is probably storage disease is the first consideration. And when we took the history, the only clue we got is whenever the child is put on endotracheal tube, child breathes normally, oxygenation becomes normal. Need not ventilate the child, endotracheal tube. And when they pull out the endotracheal tube, patient becomes symptomatic. So that way the diagnosis becomes laryngomalacia. Usually laryngomalacia, if the child survives for 6 to 1 year, it will improve. But this child has got a severe aspiration pneumonia, bilateral, and we could not continue with that child. We lost the child. This is another case. Probably you will be having the diagnosis. We missed the diagnosis first. This is a pediatric ICU patient, 2.5-year-old boy with a lot of respiratory symptoms, wheezing, cough, and failure to thrive. So that child was shown to us, and I was thinking of cystic fibrosis in this patient because child was very small at the age of 6 to 8 months only, 2.5-year-old child. And detailed history showed that whenever the child is fed, he vomits, and then the symptoms aggravate. It's a tribal child. And I asked for a CT thorax, and CT thorax showed the clue. You can see the esophagus. Dilated esophagus with a lot of food debris in the esophagus. So the diagnosis, seeing the CT, diagnosis is very clear. It is achalasia, congenital achalasia in this child. And this is the barium was taken after CT. So this is, and this case was operated in Calcutta Medical College. So that way, it's a rare diagnosis. So sometimes we'll have to think of other causes, congenital causes, or some other causes which may be the leading factor for development of such diseases. So children treating pediatric cases, we'll have to look at all these points also. This is the treatment. And sometimes hospitalization, you know hospitalization, what are the factors in hospitalization in this child. And by presenting this oration, I don't know whether you are convinced about the pediatric pulmonology, but my take-home messages are severe viral infection cause considerable morbidity in infancy, and they have been associated with the onset of long-term diseases such as asthma. Not only asthma, these children can have failure to growth of lung and develop COPD in later life. That's a new theory. Although the majority of children who develop virus-induced wheeze in infancy recover, up to a third of children develop persistent wheezing suggestive of asthma. Factors which impair fetal and childhood lung growth can set the stage for lifelong functional derangement which persist into adult life. With these in mind, pulmonologists should approach children with respiratory disease. So that is my point here. So there are so many things, and if we prevent the disease at an early childhood stage, we can prevent development of chronic lung disease in this child. Sometimes this child with bronchiolitis may be presenting to you at the age of 55 or 60 with COPD. So we can prevent such things if we take care of these children to an extent. The idea is the pediatrician should get an opinion from the pulmonologist whenever it is needed, and we should be able to give a definite expert opinion in such case. So that is my presentation. Thank you. Wishing you all a happy 2022. Thank you, APT, for inviting me, and thanks to all the delegates for patient hearing. Thank you very much.
Thank you, Ravindran sir. The message is very clear. The pediatric lung is not a miniature of adult lung. The bugs affecting the pediatric lung is not same as adult lung. And if we misdiagnose, if we mistreat a pediatric lung, it is still has to grow and lot of potential, and it affects the adult life too. So as a pulmonologist, we should also have some pediatric training, or the pediatric lung physiology and the pediatric pulmonology we should learn and practice it. And similar to that, the pediatricians who are looking to the respiratory system also should have some pulmonary medicine training too. Thank you, sir, for this wonderful message.
Thank you, sir. Next, we have the Dr. N. Mohanan Memorial Oration. And we have the orator, Dr. Kurian Thomas. Sirne ആദരിക്കാനും പൊന്നാട അണിയിക്കാനുമായി ഡോക്ടർ A.K. ജംഷീറിനെ ക്ഷണിക്കുന്നു.
I'm deeply honored to welcome Dr. Kurian Thomas sir. He has joined for DTCT in Government Medical College Trivandrum in 1983. Since then, he has been attached to Pulmonary Medicine Department in Government Medical College in Kerala. Mainly attached to Chest Hospital, MG Kavu, Thrissur, with effect from 1989. And was professor at Thrissur from 1999 to 2007. And he took his URS and is now working as consultant pulmonologist, senior consultant pulmonologist at Thrissur. Apart from this, his son was my batchmate, MBS batchmate, and he's Dr. Thomas Kurian, and I'm very glad to make you know that, and I am very glad to invite sir for this Dr. Mohan oration, memorial oration. Thank you.
ഡോക്ടർ കുര്യനെ ഇപ്പോൾ പൊന്നാടി അണിയിക്കുന്നതാണ്. Thank you, sir.
At the outset, let me thank APT President Dr. Thomas Vadakan and his team for giving me this opportunity to deliver the N. Mohan Memorial Oration. It's my pleasure and privilege to do this oration because my tenure in Trichur as assistant professor and as a clinician has been very much entwined with the career of N. Mohan. Right from my joining as tutor in 1985 to my retirement in 2007, I had the privilege of having such a dear friend working along with me. He was in the health services, I was in the DME service, and in Trichur the two services are together. And in this age where there is even intra-departmental rivalry, at that time we had a very nice time along with N. Mohan, initially as lecturer, as assistant professor, then as I was the professor and he was the head of the government service. And we had a nice time. And he had a lot of achievements as a pulmonologist connected with these associations. He was in the APCCM president, he was the APT president. He was a very active member of the KGMOA also. And he was very much involved in the RNDCP program also. And it was because of him that the RNDCP of Trichur district was taken over by the medical college department, because he was always there to give me, advise me. And N. Mohan was such a pleasant gentleman, very soft spoken, and always there to help me. If I look back and look at my colleagues, my senior colleagues and juniors who has worked with me, if there is one person I could say, a silent worker who was a very good friend, whom I have never seen irritated or angry, or it was Mohan sir. So I bow before his memories. He left us too early for his good-naturedness, and may his soul rest in peace. Now coming to the topic, asthma is one of the commonest of chronic illnesses. Even Professor C. Ravindran has also dealt so much on asthma, because it's there in children, it's there in adults, it's there even in your deathbed if you are an asthmatic. So asthma is one of the commonest chronic illnesses affecting up to 20% of human beings during their lifetime. It causes a lot of preventable sufferings in cost, morbidity, and occasional mortality. Asthma is a safe disease. It doesn't damage the lung tissue much. It even spares the airways of permanent damage. Asthma is a disease which the asthmatic often quickly learns to live with. What is asthma and how does it look and behave? The beauty or the ugliness is in the eye of the beholder. What do you see in this picture? Do you see the young lady's face or the old witch's face? Depends on your outlook to the picture. So in the same way, the outlook to this particular disease, that is asthma, depends on who is having it. The concept of the illness and its treatment and cure, the perspectives are entirely different to each one of the stakeholders. For a child, it's only of nuisance value for his play and the school days. For its parents, it looks frighteningly different. For the asthmatic spouse, it is a nightmare at 4 a.m. For the pulmonologist, it is his commonest patient, as well as his breakthrough phone calls at odd times. For most Indian asthmatics, I can vouch this, they are more afraid of the treatment than the disease itself. The treatment to each one of us in this room and who are online, we all know, we could all vouch for its double safety. So the treatment for asthma for the pulmonologist also straightforward and well researched and agreed upon with good international guidelines, with hardly anything to add in these days. So then why this suffering? That is my question. Why asthma is still not fully controlled and has many reasons and components. For us as doctors, when we look at this problem from our side, the fault line is with the patients. And it's very simple. He does not follow our instructions correctly. Why is it like that? Let us dive into the patient's perspective of non-adherence. And 50% of patients have got some form of non-adherence. So that is the aim of my talk. This is an area which is not well researched in pulmonology circles. Now, because of the variability of asthma, you start treatment depending on the severity of the illness as told by the patient, by the examination and tests and every review assessments. But once treatment is fine-tuned, as this asthma guideline says, from then on the focus is on achieving control. That is by regular visits and regular intake of appropriate drugs and doses as the doctor advises. Now there is many a slip between the clinical trials. In clinical trials, there is control in majority of patients, while in the consultation rooms, there is poor control and exacerbations. These exacerbations are a major burden for both the patients as well as the treating health systems, whether it is private or the government funded. And why this poor control is because unlike R&DCP, where the system determines the treatment outcomes, here the patients can make free choices, and there is always a conflicting priorities and perceptions between the patient and the doctor. As Robert Brown said, the best laid plans of mice and men often go awry. The choice is between the mouse and we men. You know whom I am telling as mouse. Now the well thought out plans go haywire in the thick of the battle. That is the battle between the patient, the asthma, and our own treatment plans. Because as per law, our treatment plans and the patient's choices may not tally together, and patients are free to make their choices as to what they have to take. So for causes for poor asthma control are many. The first is the disease. Sometimes we may land up with difficult asthmas due to trigger exposure or comorbidities, or it may be due to the doctor. Because he is not an asthma specialist, he is far away from the specialty, there might be inadequate assessment and inadequate treatments. But for today's discussion, I am mainly concentrating on the patients. That is, the reason from the patient side is that even the best doctors can take these asthma horses or patients to the water, but you cannot make them drink due to the low adherence to an agreed treatment plan and skipping of reviews. So for poor control, the reason may be the clinical asthma. Occasionally we have got very severe asthmas, genetic reasons, type of asthma, or comorbidities. For example, COPD along with asthma. But most of the time, it is the behavior of the clinician and especially the patient which is the stumbling block for correct asthma outcome and reason for patients' non-adherence. I again tell we are mainly discussing about patients' non-adherence only. So for correct asthma treatment outcome, effective treatments are available, the outcome depends on the behavior of the doctor and behavior of the patient. Now, the doctor's role is, the healthcare professional's role is to prescribe the correct medications and to conduct correct reviews and take appropriate actions when the patient loses control. And from the patient side, the importance is taking the medicines appropriately and coming for follow-ups. If it is correctly done, the outcome is good, the optimal outcome. But the rate limiting step is mainly the behavior on the part of the doctors and on the part of the patients. Today we are discussing why patients are not behaving as per our advice. So why do asthma patients go to the trouble of consulting an asthma specialist and then fail to adhere to his instructions? And why does this appear to worsen over time? Adherence seems to worsen over time. We all know in tuberculosis treatment, that is what is happening. The patient not only initially defaults, but defaults in between the treatment also. Now, the scientific study of non-adherence is well researched. This applies to not only asthma, but applies to all chronic illnesses like treatment for diabetes, treatment for hypertension and all. So, but it is not well discussed in pulmonology community, these non-adherence reasons, other than in R&D-CP treatments. Now, this is what they call as the perception and practicality approach, or called the PAPA approach, PAPA approach. Now, when we doctors give advice to patients about the disease they have and their medications, they will already have a belief about the illness. That is, the identity of the illness. Asthma is different thing to different people. The cause of the asthma, the timeline of the asthma, or what we call as the natural history of asthma, and the consequences which we call the sequelae, and the control of cure of asthma which we call the prognosis. They all have a belief system about the medications, that is the necessity for the medications and the concern for the treatment which we give. Concern especially about the side effects of the medications. Now, if the belief about asthma and the belief about the medications and its side effects, if it makes common sense to the patient, they will have an intention to take our treatment, and then they will be treating. And if there is some non-adherence, it will be mainly due to practical issues like the cost of the medicines, the patient is forgetting things. So all these can be easily managed. But if the belief is if the perception is not correct, there will be non-adherence. So the issue is non-adherence can be due to perception difference or practical differences. And this is the idea behind the perception and practicality approach to non-adherence. This has been well researched mainly in UK by pharmacists, because pharmacists are the people who are giving these medications most of the time in UK, and the main research is by pharmacology professor Rob Horn. So practical issues are something which we can easily manage, because there is the non-adherence is unintentional. The reason may be capacity or resource limitation influencing the ability to treat. For example, in these times, the practical barrier is they cannot come for reviews because of the lockdown. So what could they do? The number of phone calls I had during the lockdown asking patients that what shall I do? Shall I continue the same medicines? I'm having an acute attack. Those are all practical issues where the patient has got intention to treat, but he's not able to do that. And then next is the perceptual barriers. Next is the perceptual barriers. Perceptual barriers are intentional non-adherence. The patient doesn't want to continue with the medications because he has got wrong beliefs about the disease and wrong beliefs about the treatment, which influence the motivation. And this is the one which is more difficult to treat. Treat in the sense to get over. So information when we give to the patient, either about the disease or about its treatment, information even from trusted sources like us, whom most of the patients believe, is not sufficient for the patient to follow our advice about medications. It interacts with their belief, and if it is not in concordance with their preconceived beliefs, they may not follow your advice. So our information either has to tally with their belief or it has to change the already preconceived wrong belief. So poor adherence is nothing new. In 2000 BC, Hippocrates has told that to be alert to the faults of the patient, which make them lie about their taking of the medicines prescribed, and when things go wrong, refuse to confess that they have not been taking that medicines. This is very common for us pulmonologists. It is there in tuberculosis treatment. It was there at least before the directly observed treatment, and it's there very much in asthma treatment also. So it's not what you look at that matters. It is what you see. What you means not the doctor, but who is sitting across, what he sees, which matters. So what do you see in this picture? I don't see anything, but some of you might be seeing a lady with a lamp on a window, or some of you may be seeing a man with a mustache. It depends on your perspective. So adherence to treatment for all chronic illnesses, it depends on lot of external factors outside the doctor's control. It depends on the perception about the disease. The information may be correct or it may be false propaganda. And who is communicating the things to the patient? We healthcare professionals and lot of friends also give them advice. Some of them may be conflicting. There is a lot of cultural influences, the social support to the patient, and in this age, the media, the social norms, view of significant others, all these matter, especially when we are talking about allopathy treatment in India. The culture is such that it's always viewed with the element of skepticism. So let us get back to that the scientific rationale. Now, when we have a diagnosis and a treatment, the patient has got a view about the prescribed medications. He views it, what is the necessity of this treatment? Beliefs about personal need for medication to maintain or improve the current and future health. And he has got also a lot of concerns arising from beliefs about the potential side effects of medications. And then he makes a common sense idea about the necessity for these medications. Patients do not blindly follow health advice, even from trusted clinicians. Rather, we and the patients all evaluate the advice and decide whether to follow it based on our own common sense understanding of the illness as well as its treatment. And patient mentally need a common sense fit between our illness and the treatment. The solution has to fit the problem. And patients' common sense evaluation of treatment are influenced by subjective symptoms, experience relative to the expectations. Patients with the same illness prescribe the same medications differ in their perception of personal need. Some patients think that my health depends on these medicines, I am going to take it. Others think that this medicine has little effect on my health. Then there is another group who thinks that this medicine protects me from becoming worse. And with regard to the concerns, especially in India, especially even in Kerala, the patients have got strikingly similar concerns, that is unpleasant side effects, regular use may lead to dependence, long-term use may lead to harmful accumulation, then this medicine has got a disruptive effect on my lifestyle. I know a lot of patients who tell that I am getting married, I simply cannot take the inhaler to my husband's house. It's impossible, sir. I just cannot take it. So that is what I'm telling about the disruption to their daily life. So idea in this context about adherence, what we have to do is that we have to create a concordance between the ideas of the patient and the doctor. We should have shared understanding between the asthmatic and we physicians, where often there are two sets of sometimes opposing beliefs about the nature of the illness, that is the asthma pathophysiology from our term, about the appropriate treatment, that is from our side it is a chronic airway inflammation, and are each of these assumptions shared and declared by the doctor and the patient? If not, then the consultation may be non-concordant and the failure to reach an agreement or shared understanding, and non-adherence will be more likely. And patient-related determinants of asthma control, we all know. Patients' expectations and aspirations about asthma is half the asthmatic would be telling that this is not asthma. Some of them will tell this is the maximum possible relief. I am going to stop the medicines. It is okay. While the PFT may show some reversibility, some tell that I am cured. Why do you want to ask me to take the inhalers more? Some think that it will not recur. Some tell that this is there to stay. So I don't want an inhaler. I have been using this I am having these medicines for such a long time. So we need to raise the bar of the achievable with regard to asthma. My own off-the-cuff mark is that at least 90% of the sufferings of asthma can be very easily controlled if it is well managed. Now, what level of asthma control do patients want to achieve? We should know that patients make choices between the different attributes of their disease and its treatment. Especially I am talking with regard to inhaled corticosteroid as a group. They will tell that I am going to stop the inhalers because I have achieved the control which I wanted. So just like a consumer chooses an item for purchase, asthma patients choose our medicines versus their sufferings. And of course, at the end of the day, there is no patient-defined endpoint as a marker for improvement or cure in asthma. So patients and doctors, when we meet, we have to balance between the necessity for the medications and the necessity for medications and the concern regarding the medications. If there is high necessity and low concern, there will be concordance and there will be good cure. And if it is low adherence because they are much more concerned about the medications, there will be low adherence and low treatment outcomes. So, judging the personal need for asthma treatment, the importance of common sense understanding for asthma. This is what we have to do. We have to convince the patient for a need, that is, there should be a good fit between the problem of asthma and the solution which we offer. The notion of asthma as a chronic condition needing continuous treatment is at odds with the experience of an episodic problem. Just like an epilepsy patient has got so much of problem when the anti-epileptics are continued for the third year and the fourth year without any episodes for the last 1 year. They stop it and then they throw off a fit unless they have got an EEG. The same thing applies to asthma, but in a different context, because the recurrence of asthma is almost unpredictable, unlike a EEG. So missing doses is factually okay. I forgot the inhaler for 1 week because of a death in the family, but nothing has happened. So why should I continue that? So we have to provide a convincing story for that individual for the personal need for ongoing treatment even when they are asymptomatic. And the asthma treatment role is a prophylaxis model. And so we have to elicit and address the concerns, and we will have to tell them that the benefits are silent and long term. The benefits of anti-asthma treatment and are silent and long term. I don't think in these days it's very easy to tell that these medicines are silent and long term. For example, suppose you give this inhaler to a patient who is having asthma episodes, and lifelong he never had a attack. But he is going to question you and telling that I have been taking these inhalers for the last 50 years and I am going to sue you because the side effects made me wrinkled, fat and bald. So benefits are silent and long term. So we have to address each patient's perception about his disease. There are some core concerns regarding the steroid part, regarding the inhaler part, the side effects, long-term effects and dependence. We have to tell them that it's not a major problem. The inhaler as a disruption to life, we have to convince them that it's not like that. And there are a lot of disease-specific concerns also. Just like hypertension or diabetic, there is a lot of asthma disease-specific concerns which we have to address. What we means the doctors and even the companies in the pharmacy, pharmaceutical, in looking at solutions, we means the doctors and the pharmaceuticals have probably given too much priority to the technical engineering solutions, that is Newtonian solutions, and not enough to psychology solutions, especially health psychology and behavioral medicine, because companies are coming out with the valve spacer, this, that, small spacer, counters and all, while at the end of the day, it is not the counter which is it. The patient is afraid of your inhaler. That is the reason why they are coming with the counter telling 120 at each visit. So the perception is very, very important. For we Trichurians, we know that how many legs an elephant has got. But if I ask you, how many has got this elephant got? So it depends on your perception and how you look at a problem. So in asthma also, our perceptions are different. I think this elephant has 1, 2, 3, 4, 5, 6, 5 or 6 legs. So how you look at the problem is very, very important. And how the asthmatics look at their problem is also slightly different. So from their perspective, if you look, we could give them a convincing story that this is the correct way of going about it. So what are our 5-year plans for asthma treatment? Communicate a common sense rationale for our treatment plans, especially why prophylactic maintenance treatment, especially with inhaler, is needed. Make the patient perceive a close fit between this problem, that is asthma as a localized genetic airway disease with acute and chronic inflammation. The solution, regular maintenance treatment, especially inhaled drugs, especially inhaled steroids. And a convincing asthma story we have to give the patient about a concept of the disease, its needs, and his concerns. We have to clarify and modify the wrong concepts. So we have to give truth as a good story, plausible from the patient's perspective versus the adamant myth which is there in the air. Story, why continuation treatment should be required even when the patient is okay. Elicit and address his concerns. Listen, learn and expose patient's perspective. Encourage patients to express doubts and concerns. Inform the treatment choices by the patient after knowing the risks and benefits. Allow honest disclosure of non-adherence, both intentional and otherwise, because many a time patient doesn't reveal non-adherence, because non-adherence the patient thinks that would be taken as a disbelief in the doctor's treatment, while the fact of the case is it is because of his fear of the medications rather than not because he doesn't trust his physician. So the key challenge is empower our asthma patients to make correctly informed choices about medicines rather than misplaced beliefs about the benefits and harms. So So the different components of a good asthma treatment outcome are what the stakeholders bring to the table. The patient has got a baggage of misinformation he brings to the table. The doctor might be an asthma expert, but he also has no idea why patients are not following his written and oral instructions and adhering to his treatment. Only very occasionally does the treatment, only disease play tyrant. And there is a very faulty social representation of allopathy treatment as a class, especially asthma treatment, especially inhaled medications and long-term preventers. The idea among other stakeholders are also far from true, and guidelines also do not emphasize this adherence side very much. So the medical treatment is trumped by the behavioral psychology. So what we have to give these patients is that we have to give them a new perspective regarding the asthma as a disease which is easy to treat and easily safe. So the power of reframing things in a new perspective for each patient cannot be overstated. They are more relevant than facts. Many a time, giving a patient a new perspective and psychological solutions are more important than our technological solutions. So, this is my last slide. Asthma is an easy disease to treat. In spite of the available medicines at our disposal, asthma patients who are our partners in this game of cards or bridge, should I say, they have got a lot of misconceptions about our treatment plan. So we are dealt a very poor hand from the patient side. They doubt about our knowledge of the game, our intentions, our motives or ulterior motives. They doubt about the undoubtable about doctors and medicines as a class. Allopathy phobia is there in the air. They have completely no clue about asthma, inflammation, which is chronic and hidden. So they shift from system to system and doctor to doctor. But our aim is to go on injecting logic and science into each of them. We should have the attitude of training a group of illiterate children a new language and logic, that is the asthma, the scientific asthma logic. First, understand the scientific basis of non-adherence from the patient's perspective. Then only we should try to convince them our asthma treatment logic in any which way which we think is appropriate, which looks logical to them. Then only we will achieve full adherence to our treatment plans. Thus the story will have a happy ending. Then they will live happily ever after. Thank you.
Thank you, sir. It was a quite impressive talk by you. And as sir has mentioned, bronchial asthma is a very simple disease to be treated, and we have wide range of medicines also nowadays available. But it's the duty of the treating doctor to ensure the adherence of the patient to the drug, so that we have good results. Thank you, sir.
Thank you, sir. With that, we have come to the end of our APT orations. Next, we have a next set of case presentations. And for the same, I introduce our judges back onto the stage. Now we'll begin with our case presentations. Next is our case presentation 4, hydropneumothorax in a patient with eosinophilia.
Okay, good afternoon. Presenting before you an uncommon culprit in a common malady. A 41-year-old male hailing from Bihar, working in Kerala in a furniture shop for the past 4 months, presented to us with complaints of
cough, dyspnea, hemoptysis and fatigue of 3-month duration, and a complaint of right-sided pleuritic chest pain of 1-day duration. History of presenting complaints. He presented with complaints of gradual onset progressive exertional dyspnea from grade 1 to grade 2 MMRC for the past 3 months, with associated cough with mucoid expectoration and episodes of streaky hemoptysis. He also complained of increased fatigability. He consulted local hospital 3 weeks ago for the above complaints and was given IP care for 5 days with IV antibiotics. He improved symptomatically and was discharged. He was able to continue his work though a grade 1 dyspnea and occasional cough persisted. Now he presented to us with sudden onset of lower right pleuritic chest pain and increased breathlessness of 1-day duration. He had no complaints of orthopnea, PND, palpitation, no other bleeding manifestation, no history of fever or constitutional symptoms, no history of hoarseness of voice or dysphagia. Past history, he gives no history of asthma, allergy, cardiac diseases, COVID infection, tuberculosis, drug intake or malignancy. Family history, he is a second child of non-consanguineous marriage with no other significant history. Personal history, he hails from Bihar, working currently in Kottayam in a furniture shop. He is a non-smoker who consumes mixed diet with normal sleep. Bowel and bladder habits were also unaltered. Moving on to the clinical examination, he is conscious, cooperative and oriented, moderately built and nourished, with no pallor, icterus, cyanosis, clubbing, lymphadenopathy or edema. Vitals were stable with a pulse rate of 101, regular, normal character and volume, BP of 130/90 millimeters of mercury, respiratory rate of 28 per minute, saturation levels of 91 with room air, and he was also afebrile. Head to foot examination was found to be within normal limit. Examination of the chest, the breath sounds were decreased in right mammary, right infraxillary and right infrascapular area, with a hyperresonant note in the right mammary, right infraxillary and right infrascapular area. Vocal fremitus and vocal resonance were decreased in the above mentioned areas. Overall, the findings were suggestive of a right encysted pneumothorax. Other system examination was found to be within normal limit. Moving on to the investigation, the routine blood examination revealed a hemoglobin level of 11. The total count was slightly elevated, 13,590. The differential count showed predominant eosinophilia with a 62%. Hence, we also did an absolute eosinophil count, which was again found to be elevated with a level of 8,540. Serum IgE levels were found to be again elevated with a level of 2,570. ESR was found to be slightly elevated, 48. We also did a COVID RT-PCR considering his symptom of cough and dyspnea, which was negative. Viral markers were also found to be negative. Other investigations like LFT, RFT, serum electrolytes, urine routine examination, and investigations of bleeding parameters were found to be within normal limits. ECG also showed no significant abnormality. This is the first X-ray that the patient had taken while during his admission in the local hospital, which revealed left lower zone consolidation. Again, we can see right lower zone patchy infiltrates and a few infiltrates again in the right upper zone, for which he was treated symptomatically. This is the X-ray with which he presented to us. Here we can see the right encysted pneumothorax, which slight mediastinal shift to the left. And also we can see some infiltrates are persisting in the right upper as well as lower zone. The left lower zone infiltrates are significantly cleared compared to the previous X-ray. We also proceeded with the sputum AFB and sputum CBNAT. Both of them were found to be negative. Pleural fluid study, this fluid was straw colored. It was also the study suggestive of lymphocytic exudative low AD effusion. Pleural fluid cytology showed few scattered lymphocytes with no eosinophilia or ova of any parasites. This is the X-ray taken post ICD insertion in view of pneumothorax, which showed the lung has expanded with minimal effusion persisting in the right side. So we have a young male from Bihar who presented to us with complaints of cough, exertional dyspnea, episodic hemoptysis, bilateral lower zone patchy infiltrates, right pneumothorax and peripheral eosinophilia. The possibilities we considered were the first, tuberculosis being the most common infection. It was the first differential diagnosis we considered. We also considered possibility of other bacterial pneumonias. Considering his eosinophilia, though he gave no history of asthma or atopy, we also considered the possibility of an asthma ABPA. Acute eosinophilic pneumonia was another differential diagnosis considered. Again, we considered possibility of parasitic infections, tropical pulmonary eosinophilia, as well as Loeffler syndrome. Malignancy was also kept in mind considering his prolonged symptoms of hemoptysis. So, however, we proceeded with the peripheral smear, which showed microcytic hypochromic anemia with marked eosinophilia of 66%. Stool routine examination as well as sputum study for parasites were done considering his marked eosinophilia. Both were found to be negative. We proceeded with the CECT thorax to rule out any lung masses or lesions in considering his prolonged 3-month history of hemoptysis. Here we can see right lower zone patchy infiltrates with minimal right effusion. Again, in this cut, we can see there are also infiltrates present in the left lower lobe. This is again the CT showing patchy consolidation bilaterally. So, in view of this hemoptysis persisting, we proceeded with the fiber-optic bronchoscopy to rule out any source of hemoptysis and whether any intraluminal lesions were present. The bronchoscopy showed increased secretion in the right lower lobe superior segment. BAL was taken from the right lower lobe superior segment. Along with that, we did a TBLB from left lower lobe lateral basal segment, considering a patchy consolidation that was persisting there. The BAL, AFB and CBNAT both were found to be negative. The BAL culture was again negative. BAL cytology showed reactive bronchial epithelial cells, macrophage and eosinophils. The transbronchial lung biopsy showed lung tissue with mild inflammation, showing lymphocytes and neutrophils with scanty eosinophils. This is the image that we have from the BAL direct microscopy. Here we can see a barrel-shaped double-layered egg with unsegmented ova, which is suggestive of Paragonymous westermanni egg. The patient was treated with ivermectin, DEC and albendazole and praziquantel 25 mg per kilogram TDS for 3 days, after which he became symptomatically better. His peripheral eosinophilia also improved. Hence, we have a diagnosis of pulmonary paragonimiasis here. So, we have a take-home message that is Kerala is a state with significant influx of migrant laborers from northern states like Bihar, West Bengal, etc., where endemic hemoptysis is commonly found. So, we should also consider the possibility of Paragonymous westermanni infection whenever a patient presents to us with hemoptysis, though this infection is not commonly found in Kerala. Thank you.
Thank you. A very rare disease is highlighted here, a parasitic infection present as hemoptysis. So you are considering the possibility of acute eosinophilic pneumonia. What's the definition of acute eosinophilic pneumonia? And when do you say it's chronic eosinophilic pneumonia?
Sir, acute eosinophilic pneumonia usually presents with a symptom of short duration, less than 1 month duration, fever with respiratory symptoms. Then we also have
this patient comes with a 3 months history.
Yes, sir. Yes, sir.
So why do you say it's acute eosinophilic pneumonia?
So both acute as well as we mainly consider of chronic eosinophilic pneumonia because it was a prolonged symptom. 3 month duration was there, sir.
Okay, and you are showing 62% eosinophils in the peripheral blood, but BAL showed no eosinophil at all. And the tissue biopsy also did not show eosinophils. How do you explain that?
Sir, in the acute, it might take a more longer time period from 3 to 4 months for the pulmonary eosinophilia to develop. In the initial stage, it might only show peripheral eosinophil count, sir.
What is the possible mechanism of pleural effusion in this patient?
Pleural effusion, sir, it might be, this is mainly diagnosed as a pneumothorax. There is a possibility that it was a reactionary effusion or also might be due to hypersensitivity reaction to the Paragonymous infiltration, sir.
But the pleural fluid showed only lymphocytes, no eosinophils at all.
No eosinophils at all were seen, sir. Most probably it might be a just a reactive effusion secondary to the pneumothorax, sir. There is a possibility, very less amount of fluid only we could obtain, just about 10 ml, and there was not significant effusion, sir.
What are the lung manifestations of Paragonymous? Commonest presentation?
So clinical symptoms, sir?
Yes, please.
Yes, it mostly presents with cough, shortness of breath, fever also can be seen, sir. Hemoptysis also is a rarely common, rare finding that we can see in pulmonary paragonimiasis.
Thank you.
hydropneumothorax and pneumothorax are both are presenting symptoms.
Dr. Maria, thank you for presenting this particular case, especially when a person from Northeast India comes. One differential diagnosis, paragonimiasis. But two atypical points I want to mention is paragonimiasis is usually upper lobe involvement. Can you hear me?
Yes, I can hear you, sir.
Usually upper lobe involvement with cavitation, fibrosis, just like tuberculosis. And
Yes, sir.
pneumothorax is a very rare manifestation of paragonimiasis. Very rare.
Yes, sir. Yes,
Then you said that rarely hemoptysis, but it is not rarely hemoptysis. It is mostly hemoptysis. The name of the disease is endemic hemoptysis.
Endemic
isn't
hemoptysis.
it? So that is why it is hemoptysis is a predominant symptom. And in the differential diagnosis, one important differential diagnosis you missed is granulomatosis with polyangiitis, eosinophilic granulomatosis polyangiitis. This particular patient with a 66% of eosinophils and migratory pneumonia on both sides.
Both sides, yes.
Important diagnosis is one differential diagnosis is eosinophilic granuloma with the polyangiitis. In that case, you will have some skin lesion also in that patient. You can easily rule out skin lesions are not there. Then you can rule out, but that also will become a differential diagnosis in this patient.
Diagnosis, yes, sir. Yes, sir.
Any questions?
As a pulmonologist, when you will suspect this eosinophilia with angiitis, previously called Church-Strauss, he was mentioning about it. What are the presentations of those patients?
Sir,
as a pulmonologist, when will you suspect it?
Sir?
As a pulmonologist, when will you suspect Church-Strauss syndrome? Eosinophilic angiitis.
Yes, sir. Eosinophilia along with vasculitic symptoms will be also manifesting. Then we'll also have to consider the differential diagnosis, sir.
When a chronic asthmatic patients with allergic rhinitis come with features of neuropathy or skin lesions.
Yes, sir.
And then you find eosinophilia, you suspect it. This patient did not have any history of asthma or allergic rhinitis. Am I right? She didn't have any allergic symptoms. Asthma, sneezing, nothing like
No,
that.
sir.
So commonly you don't suspect this diagnosis.
Yes, sir.
Anybody want to ask questions? No. Thomas?
Yeah, my question is that the left lower zone lesions resolved in the second X-ray without starting the antiparasitic treatment, whether it is part of eosinophilia and whether any steroid was given in between.
No, sir. There was no steroids were given, sir. He was treated only with IV antibiotics from the local hospital, and after which he presented to us.
What's the other name for paragonimiasis? Boom.
Sir, oriental lung endemic hemoptysis.
Lung fluke.
Lung fluke. Lung fluke. Yes, sir.
Cavity, cystic lesions, fibrosis, that too in the upper lobe you get most of the time in paragonimiasis.
Sir, hello, sir.
I just want to mention that it is a differential diagnosis for tuberculosis in endemic areas.
Tuberculosis,
especially
yes, sir.
Assam, that area it is very endemic. Any questions, Dr. Kurian, you want to ask? Ask questions and promote students.
Presentation, Maria.
Thank you,
One
sir.
differential diagnosis you mentioned was the acute eosinophilic pneumonia, where you don't get that much of peripheral eosinophilia. So that should not have been the one of the differential diagnosis.
Yes,
Second, you said in the presentation you said the vital data are stable, but two of the important vital data, that is the pulse rate as well as the respiratory rate, was at the higher
yes,
side.
sir.
So that also
Yes.
is not. You cannot say that it's stable. And what was the profession of this patient? How did he acquire this paragonymous?
Sir, he was partially working for 4 months in Kerala in a furniture shop. He was
Usually
working.
paragonymous is
Yes, sir.
usually occurs in patients who dive to the in the sea. I think
Sea,
it's
yes.
related to the mussels and the snails.
But he had history of consuming, sir,
And
crab.
crab.
But we asked the questions he mentioned, but not recently. While he was in Bihar, he had history of consuming crab.
Okay. One of the presentation of paragonymous is mass lesion. We had a case of mass lesion where both the malignancy as well as the paragonymous was isolated. So that's also another presentation apart from the presentation like tuberculosis. No.
Yes, sir.
Thank you.
Thank you, sir. Thank you.
Thank you for the nice presentation. But I have one question. Your first DD was tuberculosis.
Yes, sir. First DD was tuberculosis, sir.
The infiltrates were mostly on the lower side.
Yes, sir.
And eosinophilia was a prominent feature.
Yes,
and
sir.
still, why did you go for TB as a first DD?
Sir, considering the common is always common, we consider the possibility of tuberculosis only first, sir. But still, he was migrant labor. Considering the peripheral eosinophilia, we also went for considered the diagnosis of parasitic infections also. He had a prolonged history of cough, hemoptysis. The first differential diagnosis which came to our mind considering the symptoms were tuberculosis.
Okay.
Because this patient, he hemoptysis also. 3 months
Yes,
symptom
sir.
with hemoptysis. So that's why
Hemoptysis.
tuberculosis was put on.
Yes, sir.
Okay, thank you, Dr. Maria.
Thank you, sir. Thank you so much.
Thank you, judges. Next, we have our next case presentation, case number 5. Let us not forget the past.
Wishing everyone a pleasant day. Here I am to present the case of a 10-year-old boy hailing from Thanur with complaints of cough for 2 years and shortness of breath for 6 months. The frequency of cough increased towards early morning hours. There were no postural variations. It was predominantly a non-productive cough with no history of any hemoptysis. His dyspnea was of MMRC grade 1 with no diurnal or postural variations. He also had symptoms of gastroesophageal reflux disease. There was no history of any fever, chest pain, loss of weight, drop in scholastic performance. There was no history of any recent COVID infection. Regarding his past, it was an uneventful childhood till his presentation right now. There was no history of any recurrent respiratory infections or other significant illnesses in the past. No history of any developmental delay. He was also fully vaccinated for his age. He follows a mixed diet. He had regular bowel and bladder habits. He is a playful and active child who socialized well. He was also a boy who was skilled in drawing. There was no relevant family history. Let me give you a brief idea regarding the treatment history of the boy before he presented to us. So for these complaints, he was managed with cough suppressants and anti-reflux measures by a general practitioner initially. Following no relief, he was referred to another doctor who noticed mild eosinophilia, and he was put on inhaled bronchodilators with the diagnosis of asthma. Again, the boy had no resolution to his symptoms. So he was again referred to another practitioner who started him on inhaled corticosteroids and long-acting beta agonists empirically, again with the diagnosis of asthma. That doctor also noticed that the boy had a raised total IgE levels, and he was referred to another center. From that center, he was started on oral steroids with the provisional diagnosis of probable ABPA, and he was also evaluated radiologically from that center. The CT was suggestive of intralobar sequestration in his left lung, and with this diagnosis, he was referred to our department as well as Department of CVTS. CVTS department referred him back to us for further evaluation, and that was how he presented to us. So we reviewed the case, A similar history was obtained, and upon examining the child, we found that the boy was an active child with stable vitals. The systemic examination showed a normal upper respiratory tract. Regarding his lower respiratory tract, we could find that the chest movements were reduced on the left side. The vocal prematus was decreased on left mammary, infra-axillary, and infrascapular areas, with a dull note over the same areas. The breath sounds as well as vocal resonance were also reduced over the same areas. Other systems were within normal limits. We proceeded for further investigations. The routine blood examination showed a mild eosinophilia with raised ESR. His absolute eosinophil count and serum IgE also were mildly elevated. His stool routine was normal. We also did an Aspergillus specific IgE that was negative. Other investigations were also unyielding. We also subjected the patient for a spirometry, but he could not properly perform it because of his cough. And this was his radiological image when he presented to us. The X-ray was a rotated film, but it also had a non-homogeneous opacity involving the left middle zone and lower zone. As he was referred primarily to us because of a suspected sequestration, we ordered for a CT iotogram, which showed a collapsed consolidative changes in his lingular and basal segments of left lower lobe with bronchiotatic changes involving the same segments along with peribronchial thickening, as you can see from the CT. And these are the parenchymal images showing similar findings. So we were left with a big question mark. What could the boy possibly have? He obviously had bronchiectasis in his CT, but there was nothing to suggest any immunodeficiency. He does not give a history of recurrent childhood infections. His family history is nil relevant. He also was an active child. So we decided to probe for further history. During one such OPD session, we noticed that the boy was active, but at the same time very restless. We noted that the boy was meddling with the paper clips and pens in the OPD. So we just had a spontaneous thought at that moment. Could it be any foreign body aspiration? So we specifically questioned the boy's parents for that, and the boy's father gave a casual history of accidental ingestion of a pen scab 4 years ago. However, he also confirmed to have noticed it pass via stools subsequently. But again, with a strong suspicion in mind, we decided to proceed with bronchoscopic evaluation. To our surprise, we noticed a pen scab lodged in the left lower lobe bronchus, and we removed it in the same sitting with a rat-toothed forceps via fiber optic bronchoscope, and this was the pen scab. The boy was given symptomatic treatment. He was asked to discontinue steroids, and we scheduled a review visit after 3 weeks. After 3 weeks, this was his repeat X-ray, and it showed marked clearance. The boy also had significant symptomatic improvement. So, from this case, my take-home points are: a detailed history always surpasses any sophisticated test, and we should always have foreign bodies in mind, especially while dealing with pediatric population. Also, I would like to add a point here that even if we had not suspected a foreign body in the first place, we might have diagnosed it finally with a bronchoscopic evaluation, but having such strong suspicions in mind right from the start can lead to avoiding unnecessary investigations, unnecessary anxiety. It can save a lot of time and financial resources as far as the patient and the patient's family is concerned. Also, patients get treated in different ways from different peripheral healthcare facilities by different practitioners with different diagnoses in mind, often with inadequate investigations and improper management. So it is very important that we assess every case as a new case, and it's also important that we assess every case right from the scratches whenever we see a patient at the OPD. Hope this case provided a learning point to all of you. Thank you for your patient listening. Thank you.
Thank you so much. Nice presentation. Very good case. Well worked out. Now, can you please tell us what was your clinical diagnosis after examining this patient?
Sir, upon examining the child, his vitals were stable.
No, regarding the respiratory system, what was your diagnosis? You inspected,
sir,
palpated, percussed, auscultated. What was your
yes,
clinical diagnosis?
Sir, left lower lobe collapse was considered.
So what are the usual presentations of sequestration, and was this child presenting like sequestration?
Sir, usually sequestration can present as recurrent respiratory tract infections, but this child did not give such a history. It was.
What else you expect in sequestration history?
Sir, he can have chronic cough, but mostly children present with recurrent respiratory tract infections.
How do these people die then, sequestration?
Sir, massive hemoptysis can also be.
Thank you, Ramya, for an excellent presentation. One important point, why did you rule out sequestration even though the radiologist pointed sequestration?
Sir, actually, he was referred to us with the diagnosis of sequestration. So we actually ordered for a CT iotogram to confirm the diagnosis. But in the repeat CT, there was nothing to suggest a sequestration. And also there was collapse consolidative changes in the left side. Also clinically also we got such a finding. And also because the child did not present typically with a history of sequestration.
Sir asked about cause of death in sequestration. One important cause is unidentified sequestration. If the patient undergoes some laparotomy, surgery, accidentally the vascular connection may be cut and he will profusely bleed, isn't it? So that is one cause. Second is, what will happen to the bronchiectasis now?
Sir, it can have different consequences. It can resolve slowly. As a repeat X-ray also showed significant clearance and the patient showed symptomatic improvement.
Bronchiectasis definition is
abnormal and
permanent
dilatation. But sir, in some cases where it is due to atelectasis,
maybe
the changes can reverse.
If it is acute pneumonia or acute collapse, it may resolve, but if it is long-standing, patient may become symptomatic in future also. Another question is, usually this type of foreign body is aspirated to the right side, not to the left side. Isn't it?
Yes.
Why it went to the left side? Any idea? No idea.
Was also an odd
It's only guess point, isn't it? Because usually it is easy to go to the right side, such a large one, but it went to the left side. Okay. Will there be any bronchial isomerism in this patient? That is my question. Did you think of that? What is bronchial isomerism?
Sir, both sides having the same left side having the same mirror image as that of the right side.
Okay. So these are the points which sometimes we'll have to look when you do bronchoscopy. We see sometimes rarely we have had the occasion to identify tracheal bronchus, cardiac bronchus, and we may diagnose middle lobe bronchus and go to that, but it may be a cardiac bronchus. It may produce severe problem if we don't pick up during bronchoscopy. So even bronchial isomerism and all those things, when you do bronchoscopy, you can easily pick up. And this is a scenario where you will have to suspect that it may be different on left and right. So that is what I ask. Any questions? Davis, you want to ask?
Sir, there is a comment actually in the chat box.
Yes.
Sir, Dr. Kiran Vishnunarayan had said that wouldn't the child need a surgery in view of the bronchiectatic lung with cicatrization atelectasis? So eventually the child would still have needed a CT angio. That is
she answered just before, because it can revert if it is acute, isn't it? Sometimes it can persist as permanent lesion.
So actually the CT was showing peribronchial thickening in the upper lobe bronchus also. It was not confined to the lower lobe. So I think we have to follow up the patient further to decide on that. When he came for the review visit, he had improved very significantly actually. And
okay.
Nice presentation. What is the cause of increased IgE level in this patient?
Sir, probably it would be a response to a long-standing foreign body inside the bronchus.
Or it could be some other diagnosis. Or
maybe he has some other.
This is only 700, Ramya. And most of the people in Kerala will have a slightly elevated eosinophil and IgE. 700 is not at all considered significant when we take a respiratory disease. അല്ലേ ഷാജഹാൻ?
Yes,
അല്ലേ?
especially
ആലപ്പുഴയിൽ പ്രോബ്ലി എല്ലാവർക്കും ഉണ്ടാവും.
Especially in Kerala, sir. Actually, most of the patients have, especially in young children, most of the patients have some around 400, 500.
Small increase in eosinophilia as well as small increase in IgE. We don't give much importance. I don't know.
What is the normal level? Do you know what is the normal level in children? Ideal.
It should be less than 500.
Hey. 500 ഒന്നും വരില്ല.
Usually it is less than 150 international.
140 ആണ്.
150, but in
Kerala is less than 500.
But in our country it may be 500. Okay, thank you.
Renis.
Yeah, Remy, it was a nice presentation. You are giving us a take-home message not to do irrelevant test, right? Unnecessary test. May I know why you have done a serum ACE in a child who doesn't have any arthritis or eye inflammation or that kind of?
That was actually purely based on the radiological report. It had suggested a granulomatous etiology. So as he was investigated by a variety of tests from the periphery, we wanted to rule out other possibilities like sarcoidosis also, although he did not give any typical history.
Yeah, that's what pediatric sarcoidosis usually have some eye inflammation or arthritis or rashes.
Yes,
the child doesn't have all these. But it was a good case. Would you like to do virtual bronchoscopy in this case prior to planning a real fiber optic broncho?
Yes, sir. We can do that.
How does it help?
So it can help us localize the exact point of obstruction before proceeding for a fiber optic bronchoscopy.
Okay.
There are no other questions. Thank you, Dr. Ramya, for the excellent presentation.
Thank you, sir.
Thank you, judges. Now we have the final case presentation of this set, breathlessness in a pale patient, revealing the hidden culprit.
Good afternoon. I am presenting case of breathlessness in a pale patient, revealing the hidden culprit. A 63-year-old male rubber tapper complaining of breathlessness since 4 months. Increased fatiguity since 4 months. History of presenting illness. Patient presented with gradually progressive dyspnea since 2 months from grade 1 to grade 2 MMRC, associated with fatiguity and palpitation. No history of orthopnea, PND, ankle swelling, abdominal distension, autonomic symptoms. No history of fever, cough, hemoptysis, chest pain, hoarseness of voice, loss of appetite, loss of age. Past history, no history of tuberculosis, asthma, diabetes mellitus, coronary artery disease, hypertension, COVID-19 infection. No history of drug intake. Family history, no history of tuberculosis, asthma, diabetes mellitus, coronary artery disease, malignancy. Personal history, mixed diet, smoker with 100 pack per year, alcoholic. On general examination, conscious oriented, moderately built and nourished, pallor was present, no clubbing, cyanosis, icterus, lymphadenopathy or edema. Vitals, pulse rate 78, regular normal volume, respiratory rate 24, regular abdominal thoracic, blood pressure 120 by 80 mmHg, SpO2 98% room air, JVP normal. Examination of chest, trachea deviated to right, apex beat fell to left fifth intercostal space 1.5 cm to mid-clavicular line, chest wall movements decreased to left, dull nut present on sternal percussion which was extending 2 cm later to left side, breath sounds felt bilaterally equal to normal vocal resonance, CVS within normal limits, gastrointestinal system no hepatosplenomegaly, CNS no focal neurological deficit. On investigations, HB 5.5, hematocrit 17.1, total counts 8,100, N58, L31, M9, platelet 2.7 lakh, ESR 103, RFT and LFT are within normal limits. Peripheral smear shows normochromic, normocytic blood picture, WBC, TC, DC within normal limits, platelets adequate. Iron studies, TIBC 230, percent saturation to 82.6, serum ferritin 190, retic count 0.6, correct retic count less than 0.2, stool occult blood negative. Chest X-ray PA view shows soft tissue density mass lesion in the mediastinum. Lateral border shows well defined. Medial border merging with mediastinum and hilum seen. Descending aorta seen. No pleural effusion seen. Probably anterior mediastinal mass. And further investigation, we have taken CCT thorax, axial window, mediastinal cut, source, well-defined laboratory heterogeneous mass lesion extending both sides. Few necrotic areas seen. Well, fat plane well preserved with blood vessels. No rib erosion, not extending behind sternum. No effusion seen. CC to the right, lobulated well-defined heterogeneous enhancing soft tissue masses within a few non-enhancing necrotic areas within, seen in anterior mediastinum. No calcification, stick or fat component is seen. Lesion in left side 9.5 into 9.7 to 7.6 centimeter, right side 7.2 to 6.0 into 3.5 centimeters, M5 centimeters lung field. And further proceeding, we have done a alpha fetoprotein 8.9, beta HCG 0.1, serum LDH 177, USA abdomen normal study, acetylcholine receptor antibody 2.14. Serum protein electrophoresis albumin in the lower limit of normal, alpha and beta globulins are within normal limits, gamma globulins are mildly elevated, no M band is seen. Urine BJP negative, thyroid profile within normal limits. Bone marrow biopsy shows reduced red cell precursors, other lineages are normal, and bone marrow biopsy and peripheral smear and retic count consistent with pure red cell aplasia. Then we have proceeded with throughput biopsy, which shows neoplastic cells. And patient transferred to CTS for radical excision. Patient underwent radical excision and post-operative uneventful. Radical excision biopsy shows the individual cells within lobules are small lymphocytes. Second section shows a neoplasm composed of cells arranged in lobules separated by fibrous septae. And excision biopsy reports type B2 thymoma. My final diagnosis is type B2 thymoma, pure red cell aplasia. And my conclusion is anemia is rare presentation of thymoma. The association of pure red cell aplasia with thymoma is important to recognize because thymectomy is not only necessary to treat the thymoma but may have an impact on the course of the aplasia. Ultimately, a combined surgical and medical approach may be required in order to control the anemia in the patient. Thank you.
Very good case, well presented. This patient presented with dyspnea and you found that he is very anemic. Sir. So why did you go to respiratory system then? What made you think it's a respiratory case? Patient had anemia and he was complaining of dyspnea.
Because it's a rare presentation.
No, how did you land up with the mediastinum? How did you land up with the mediastinum? Aside to the pathology, we can explain dyspnea with anemia alone. Clinically, how did you reach there?
Because dyspnea is rare presentation of respiratory system. Anemia is rare presentation of respiratory system, sir.
You also said you percuss the sternum. Do you routinely percuss sternum in the examination of respiratory system? Why did you do in this case?
Routinely we will percuss sternal balance whether there is or not.
I don't usually percuss sternum. I don't know what the pattern with the chest physicians. Unless you suspect a mass there, we don't usually percuss. I do not know. How do you classify thymomas?
Thymomas classified WHO type A, B1, B2, B3, C. Type A tumor with type A thymoma with lymphocytes. Type B1 a tumor with thymic normal time function. B2, thymoma with neoplastic cells with lymphocytes and palisading effect. B3, atypia.
Okay, that's all right. Why did you check the antibodies against acetylcholine receptor in this particular patient?
Because thymoma is more comes with more problems with myasthenia gravis, so I have checked.
So what is your inference in this case?
So myasthenia gravis can also present thymoma without any symptoms.
So do you think this is a case of asymptomatic myasthenia gravis?
Yes, sir.
Thank you, Dr. Amawat, for the excellent case. Your case is thymoma with paraneoplastic syndrome, isn't it?
Yes, sir.
So you have two paraneoplastic syndrome here, pure red cell aplasia and myasthenia, isn't it?
Yes, sir.
Are you sure? Myasthenia?
Myasthenia is not a paraneoplastic, sir.
But it is positive. Test was positive, isn't it?
Test was. Thymoma can.
Okay, what precaution you will take when such patient is subjected to surgery?
So should first go. We should evaluate neurological symptoms for myasthenia gravis. We have not.
So you have to treat myasthenia, isn't it? Otherwise, patient may go in for respiratory arrest. So that is very important. And most of the time, thymoma, what happens is there will be oculopharyngeal myasthenia, which is undetected. If large muscles are involved, we detect. Otherwise, oculopharyngeal, we will not detect, and it may lead on to respiratory failure. So such patients need ventilatory management and chemotherapy for myasthenia also. So simply we cannot, since the acetylcholine receptor is positive, you cannot simply subject the patient for surgery, because there is a risk of myasthenia, precipitated myasthenia during the procedure. That is the issue. Do you know what are the other paraneoplastic syndrome myasthenia, thymoma?
Gamma globulinemia, SLA, systemic lupus erythematosus, and others myelodysplastic syndrome.
Okay, any other question?
Yeah, it was a very good case to hear. Regarding the myasthenia, you told acetylcholine receptor antibody is positive. Whether this patient undergone any neurology evaluation on a EMG to prove that any manifestation of myasthenia is there, because the respiratory complications are very important in the immediate post-op period. So whether it was done for this patient?
Yes, sir. We have kept the neuromedicine consultation. They had told that at present no evidence of myasthenia gravis symptoms. So we have proceeded further onwards.
Okay, my next question is whether this patient will have myasthenia in the future.
Yes, sir. Recurrence will be.
Right, I think thymectomy will remove the risk to a large extent, unlikely to have myasthenia in the future.
Yes,
thank you.
With that, we have come to the end of the set of case presentations for the morning. Next, we'll have a lunch break, and we'll start with our next set of case presentations at 2. We'll begin with our case presentations now. We have 2 more case presentations left. First, case 7, don't miss it.
Myself, Dr. Ania Samuel, I presenting a case of a 48-year-old male who was a manual laborer from Malappuram, presented to our OPD with dyspnea on exertion for the past 1.5 years, and which progressed from grade 1 MMRC to MMRC grade 3 for the past 6 months. And also he complains of cough with a scanty expectoration for the past 6 months and streaky hemoptysis for 1 week. No history of orthopnea and paroxysmal nocturnal dyspnea, no history of chest pain, no history of fever, sputum purulence, loss of appetite present, no history of loss of weight, no history of any other bleeding manifestation. In past history, he had complaints of recurrent episodes of respiratory infection in the past 1 year, but no history of hospitalization for the same, no history of any other comorbidities, no history of old pulmonary tuberculosis, and no history of arthralgia. In personal history, he was an ex-smoker with a smoking score of 150. Sleep and appetite reduced, bowel and bladder habits regular, and no significant exposure history. Family history nil relevant. On examination, he was conscious, oriented, cooperative, moderately built and nourished, vitals are stable, clubbing present, no pallor, icterus, cyanosis and edema, no lymphadenopathy. Upper respiratory tract examination normal and no paranasal sinus tenderness. On lower respiratory tract examination, inspection findings, trachea central, apex beat not visible, chest movements bilaterally comparable. On palpation, trachea central, chest movements equal on both sides, vocal fremitus bilaterally comparable in all respiratory areas. Percussion not done in view of hemoptysis. Auscultation, breath sounds bilaterally equal and no added sounds heard. Other systems within normal. From this case scenario, we summarized a case as a 48-year-old male ex-smoker with a past history of recurrent respiratory infection, presented with dyspnea on exertion for 1.5 years, which progressed from MMRC grade 1 to grade 3 over the past 6 months, and productive cough for 6 months and streaky hemoptysis for past 1 week. On examination, vitals stable, clubbing present, upper and lower respiratory system examination within normal. From this case scenario, we conclude to a differential diagnosis like we keep the differentials as first one is tuberculosis, it may be bronchiectasis, it may be chronic obstructive pulmonary disease or maybe malignancy. So by keeping these are differentials, we proceeded further with other investigations. All blood routine examination done, which was within normal limit, and ears are not significantly raised, Manto non-reactive, sputum AFP negative, ECG showed sinus rhythm, screening non-reactive, serum ANA and RA factor negative. Then we proceeded with chest X-ray, which was within normal limit with no significant normalities. In view of persistent symptoms, we proceeded with CT thorax, which showed a soft tissue density area in the posterobasal segment of right lower lobe, with a suspicion of an artery from the abdominal aorta tracing to the lesion, and another well-defined soft tissue density area in the anterolateral part of the left crus. So there may be a possibility of malignancy in the right lower lobe with retroperitoneal deposits. By keeping this as a diagnosis, we proceeded, this as a differential diagnosis, we proceeded with bronchoscopy, which showed an accessory segment in the right lower lobe basal segment and no intraluminal lesion. In the CT thorax, there is an arterial supply from the abdominal aorta to the lesion is present. So we proceeded with angiogram, thoracic and abdominal angiogram. This is the video showing a thoracic and abdominal angiogram, which showed a well-defined soft tissue density area in the posterobasal segment of the right lower lobe with a feeder from the right renal artery and drainage into the pulmonary circulation, and also a connection with subsegmental bronchus. It is suggestive of intralobar pulmonary sequestration. And another soft tissue density lesion anterolateral to the left crus with a feeder from the left gastric artery, and it is likely extralobar subdiaphragmatic sequestration. So from this we can conclude to a diagnosis: right-sided intralobar and left-sided extralobar pulmonary sequestration. In view of persistent symptoms and his imaging characteristics of intralobar and extralobar sequestration, patient referred to Department of Cardiovascular Thoracic Surgery for surgical resection. So from this case scenario, we conclude to a point that usually sequestration is intralobar and commonly noted in the left side. But in our patient, both intralobar and extralobar were present and intralobar on the right side. The diagnosis may be missed in adult as many symptoms and CT manifestations overlap with the other pulmonary conditions like malignancies. So from this case, we got a learning point that so we should consider pulmonary sequestration as a differential diagnosis for a patient who presented with recurrent hemoptysis, especially before proceeding for invasive procedure like biopsy. So don't miss it. Thank you.
Are there any associations for sequestrations? Are there any
Yes, sir. But in this case, there is no congenital association. But no, commonly, extralobar sequestration may be associated with other congenital anomalies,
like
congenital diaphragmatic hernia, congenital pulmonary airway malformation, scimitar syndrome.
if you don't treat this patient, what's the natural history of the disease?
Sir, if you are not treating this patient, it may be the infection may be it leads to recurrent infection as well as leads to massive hemoptysis, and further it may going with death of the patient if it is
Can it turn
present as massive hemoptysis.
Can it turn malignant? Is there a difference
No,
between
sir.
the presentations of extra and intralobar sequestration? Are the presentations same or different?
Sir, mainly in intralobar sequestration, mainly the presentation is with recurrent infection as well as streaky hemoptysis, or it may be massive hemoptysis, but the infection chance is rare in extralobar sequestration.
Dr. Sania, very good case presented. Why did you put a COPD as a differential diagnosis in this case?
Sir, because this is a 48-year-old male with a chronic cough as well as dyspnea on exhalation for more than 1.5 years. So I considered COPD as a differential, and due to the chronic cough, there may be an injury to the throat, and it may lead to streaky hemoptysis.
What is the duration of chronic cough in COPD? For diagnosis?
It is more than
More than?
2 years. 2 years.
Okay, this is a patient having a rare coincidence of extralobar and intralobar, isn't it? Very rare.
Yes, sir.
Why then the X-ray is normal?
Sir, in some cases, X-ray may be normal.
There should be some shadow somewhere, isn't it? Some cardiophrenic angle or somewhere there should be something. Such a large extraluminal, intraluminal sequestration cannot escape an X-ray. Usually, unless it is in the mediastinum, we will have to see that, isn't it?
Yes, sir.
What is the finding of bronchoscopy?
An accessory segment in the right lobe with no intraluminal lesion.
Can you enter into that segment? Accessory segment?
No, sir.
Is there any pus coming out of that? Usually this type of lesion we see pus coming from that accessory lobe because it will not be connected to main bronchial tree, so secretions will pool in this area and it will come out during bronchoscopy when we apply suction.
There was no secretions while doing bronchoscope.
Okay. Any questions from the audience?
What is the cause of breathlessness in this? You are specifically telling that patient presented with breathlessness. What is the cause of this breathlessness in this patient?
Sir, this is an intralobar sequestration with a large size which causes obstruction.
Large size means X-ray is reasonably normal, is it? So you cannot say that it's a large size.
Chance of spillover infection is there?
Yes, sir.
Have you done the pulmonary function test? You are suspected COPD in this patient?
No, sir. Patient had hemoptysis, so we are not doing pulmonary function test.
Any other questions?
conventionally we teach students not to percuss patients with the hemoptysis. But when examiners come from Tamil Nadu or Karnataka, they say nothing doing, there is no contraindication. What is the consensus of pulmonologists? This patient was not percussed because of hemoptysis.
Sania, is it contraindicated or not? Percussion.
Sir, we are not usually not doing percussion in hemoptysis.
Usually not means if it is a massive hemoptysis, you need not percuss. But streaky hemoptysis, once in a while, there is no harm in percussing. Careful percussion you have to do sometimes, isn't it?
Okay, sir.
And that's an important examination part, which if you don't do, you will miss many things. So, if it is a large amount of blood coming and there is an acute bleed, then you can avoid. Otherwise, recurrent small hemoptysis, there is no harm in percussing. You should be aware of the symptom of hemoptysis when you do that. That is the most important thing. Okay?
Okay, sir.
Anybody? Okay, thank you.
Thank you, sir.
Thank you, judges. With that, we are coming to the last case presentation of the day. Transient orthopnea, a breadcrumb trail into diaphragm fallacy.
Hello, good afternoon all. I myself Dr. Akshay Kumar, PG from Respiratory Medicine, MES Medical College. Today I am going to present an interesting case that was managed at our institute. Transient orthopnea, a breadcrumb trail into which we will see. So, a 62-year-old male smoker, fisherman by profession, presented to our MES emergency department with sudden onset grade 4 MMR dyspnea, which is aggravated on supine position, relieved on sitting up. He has grade 1 MMR dyspnea for 6 months. He also complains of occasional cough with scanty expectoration for 6 months. There is no postural or diurnal variation of cough, no history of hemoptysis, foul smelling, expectoration or chest pain. He is also an occasional alcoholic, no other known comorbidities. So coming to the physical examination, patient was conscious, well oriented to time, place and person. He was tachypneic with a respiratory rate of 24 per minute. Other vitals were normal within normal minutes, and he maintained an oxygen saturation of 98% in room air. Chest wall percussion showed dullness in the right mammary area. CV system S1 S2 hurt, no murmurs. It was within normal limit. So we ordered a chest X-ray in the emergency department. So owing to the respiratory distress, we took an AP film, and it showed right homogeneous opacity in the mid zone and the lower zone, suggestive of an elevated right hemidiaphragm. So coming to the differential diagnosis, based on the clinical presentation and chest X-ray findings, we can arrive at differential diagnosis like eventration of diaphragm, subpulmonic effusion, diaphragmatic palsy, subphrenic abscess, atelectasis or collapse. So functional imaging allows further evaluation after diaphragmatic elevation is recognized on a radiograph. So likewise, we went for USG. So the hallmark for diagnosis of diaphragm paralysis with ultrasound imaging is the absence of diaphragm thickening during inspiration. So here in this the report we got it as reduced movements of right hemidiaphragm with paradoxical movement. So you can see the pleural layer, the echogenic pleural layer and the peritoneal layer, and the less echogenic thin layer of diaphragm that's with a speckled surface here. So on the second day again we repeated the chest X-ray. This time an erect PA film was taken. So here it shows an elevated right hemidiaphragm, and you can appreciate the linear homogeneous opacity in the right lower zone, suggestive of a subsegmental atelectasis. So further evaluation, we did fluoroscopy to study any paradoxical movement of the diaphragm. So fluoroscopy is basically done with quick inspiratory sniffing efforts with the mouth closed. So basically in a non-paralyzed diaphragm, there should be a caudal motion, but here you can appreciate the cephalate motion of the diaphragm during deep inspiration, and as for expiration it is going caudally. This is on the right diaphragm. And the second picture, second video, it shows the cephalate motion again during inspiration and the caudal motion during expiration. So you can notice the paradoxical movement in both the diaphragms. So these are static images taken at the end inspiration. You can see that in the first image at end inspiration it is more upwards, and then end expiration it is going little flat. So we then ordered a CT thorax and upper abdomen to rule out any local causes of diaphragm. So local causes of diaphragm palsy. So you can see that at the level of T6 vertebra itself, you can visualize the diaphragm, and also you can visualize a collapsed lung in the mediastinal window. So once suspected for for diaphragm dysfunction, the screening can be accomplished by measuring the change in vital capacity from the seated to supine position. So in this patient, the vital capacity in the sitting position was 58%, and there was a reduction to about 31%. That suggests diaphragm paralysis. Actually, the percentage reduction being around 47%. So you can see that and the pre value was 1.6, and the post value, that is post value suggestive of, that is supine position, was 0.85, and the reduction being about 47%. So this test is about, if there is a 25 to 50% reduction on assuming the supine position from the sitting, then this test is about 90% specific and 70% sensitive. We then, as a part of evaluation, we did a sleep study to rule out any nocturnal hypoventilation. So that can be seen in diaphragm disorders caused due to neuromuscular junction disorders or myopathies. So in this, the AHI was 3.2, RI value of 5.2, which is quite normal, and the there was the lowest desaturation recorded was 82%. So based on our clinical, radiological findings, the spirometry, and also the fluoroscopy, all were suggestive of bilateral diaphragm paralysis, and now we have to focus on the cause. So on further probing, he is a fisherman, so we elicited that he dyspnea during immersion in water. There was no history of frequent nocturnal awakenings, night sweats, daytime hypersomnolence, depression, morning headaches. And on examination, we found paradoxic inward motion of the abdominal wall noticed in the supine position. So we did a thorough neurological assessment of this patient, and we found that all deep tendon reflexes were brisk with plantar reflex extensor on the right side. So while you go about the cause of diaphragm dysfunction, we have to think at 3 levels. One at the level of the nervous system, then at the level of muscle, then at the level of neuromuscular junction. So just summarizing the causes, one nervous system would be sclerosis, multiple sclerosis, stroke, GBS, motor neuron disease, etc. Myopathies would be muscular dystrophies, myositis, neuromuscular junction disorders like myasthenia gravis. So this slide basically summarizes how to go about when you get when you suspect bilateral diaphragm paralysis. So basically, chest radiograph will show low lung volumes. The vital capacity will be less than 60%, with a reduction about 30% and assuming the supine position. So here in our patient was 58% in the sitting position, and the reduction was about 31%. So that is more suggestive of bilateral diaphragm paralysis. Also, you can do the mean expiratory pressure, mean inspiratory pressure ratio, that is more than 3 here. Because here the expiratory muscle will be preserved, and inspiratory is the one which is at a disadvantage here. So the ratio will subsequently increase. Also, you can do this ultrasound. The zone of apposition, the thickening fraction will be reduced less than 20%. Then in invasive method is by measuring the transdiaphragmatic pressure. So by all these methods, you can confirm the bilateral diaphragm paralysis. And then you have to do further evaluation to know the cause, that is sleep evaluation, CT, neck, chest, possible MRI, etc. Now since we got brisk reflexes, all deep tendon reflexes were brisk, we did an MRI spine screening to rule out cervical myelopathy, and it showed cervical canal stenosis at the level of C3-C4, C4-C5 and C5-C6 level, with a stenosis of about 0.7 millimeter. Radiologically, absolute stenosis is less than 10 millimeter, and in this patient it was 0.7 millimeter. So based on our clinical examination, based on our radiological findings, functional imaging, spirometry and ultrasonogram, our diagnosis was bilateral diaphragm paralysis, possibly due to cervical canal stenosis leading to cervical myeloradiculopathy. So the patient which presented with transient orthopnea became a breadcrumb trail into diagnosing diaphragm palsy. So summarizing, diaphragm is the only skeletal muscle with a pacemaker. The diagnostic evaluation of diaphragm paralysis is a cumbersome task. It requires a systematic and multidisciplinary approach involving a series of non-invasive and invasive methods before coming to a befitting inference. Thank you.
Total duration of this illness is few months. Am I right?
Yes, sir.
So, and then he had an abrupt onset of dyspnea. How do you explain that?
So basically, the cervical canal stenosis might be only building up that he is presenting transient orthopnea. Probably if it is not treated, it might lead to a persistent dyspnea. That is, dyspnea can further increase. This might be his first presentation with orthopnea.
Why he is presenting abruptly? That's a question. When you say acute breathlessness, we have few differential diagnoses where we don't consider chronic diseases like this. Was anything acute happening to this patient? What was the SpO2 when he was lying down and when he sitting up?
SpO2 was there was not much reduction in the saturation. It was around 97% in supine position also. There was not a difference in the...
Cervical myelopathy is a very common disease.
Yes.
But we don't come across diaphragmatic paralysis as such as a presentation. I have not seen, don't know.
You said that the complication is increased dyspnea in this patient.
Yes, sir.
No. Patient will go in for quadriparesis, isn't it? C3, C4, C5, there is stenosis, spinal canal stenosis.
Yes,
what will happen next? Only diaphragm is involved. Now, spinal cord will involved.
He can develop open neurological
there is a brisk
deficits.
reflux. This is a neurological problem, very serious issue. But I am not convinced about that fluoroscopy. I thought that this diaphragm is moving down during inspiration and going up during expiration.
No, actually we are actually asking the patient, directing the patient to take deep inspiration. So basically what the negative thing about fluoroscopy is that we are not able to pan in the whole field. So the only a part of the diaphragm as well as a part of the ribs will be obtained in the image. So basically we ask the patient to take a deep inspiration, and during that time it's supposed to go caudally, but then it was going cephalad. Actually there's an audio with it.
And the X-ray showed only right diaphragm at a higher level. Then what happened to left diaphragm?
Our spirometry values and all fluoroscopy values are all consistent with bilateral diaphragm palsy. Even
how much changes will be there in vital capacity and FEC in bilateral diaphragm pulse?
If it is unilateral, it will be more than 15%, but here it was more than 60. It was around 30, more than 47% reduction. So that is.
We have seen patients with bilateral diaphragm paralysis and amyotrophic lateral sclerosis. A lot of cases we have seen. Usually unilateral, rarely bilateral, which is a degenerative disease. But this one is a obstructive cause in the spinal canal. Something will be there, and it's a neurological emergency. Surgery should be done immediately, isn't it? Yes. Otherwise, patient will go for quadriparesis.
Yes.
Okay. Any question?
Sleep study was done for this patient. Okay?
Yes, yes.
With bilateral diaphragm palsy, how could he remain in supine position overnight?
But that was the thing. The patient is having only a transient symptoms. He is not having the symptoms. From second day onwards, he was actually better. So he was not having much orthopnea or dyspnea. He was having a persistent grade 1, grade 2 MMRC dyspnea. But then that orthopnea, he presented to the ED. The next day, he was actually better. We didn't administer any steroids or anything as such.
So there must be something missing. Otherwise, he would not have got better all of a sudden if it was a compressive cause.
Actually,
more than 30%, and patient is that question is pertinent, I think, because you said that it's only transient. Did you repeat the spirometry?
No, we didn't repeat the spirometry.
So the patient is able to sleep very comfortably with FEC reduction more than 30%, bilateral diaphragmatic palsy. Is it?
No, he is able to sleep in the sense as such that orthopnea was only transient. He was having grade 1 MMRC dyspnea for 6 months, but that sudden presentation was just one time. Yes, the second day onwards he was actually better. So that was why it's 6 months is having grade 1 MMRC dyspnea, not orthopnea.
So do you want
that sudden transient orthopnea? So
could it be due to some other cause? Sir is asking, sir, am I correct? Some other cause. Or do you want to repeat spirometry?
Yeah, that would be actually good because, but in the follow-up, we would like to repeat the spirometry
and there is a whether this much reduction in
yes.
supine position or not. If
Yes, yes. No, we have not done.
One more thing, could it be any abdominal issues like any abdominal distension which transiently increased the problem, and once that was relieved?
No, we actually did
gaseous,
USG thorax and abdominal examination was
I
also.
mean any transient gaseous distension or something like that which might be relieved, because all of a sudden patient got improvement. That is a thing which is striking to me.
Yes.
Because a diaphragmatic palsy, if it is the symptoms are due to that, we are not treating that, but patient is getting improvement. So might be some abdominal distension which is pushing the diaphragm upward, might have caused the symptoms, and whatever any gaseous distension relieved. Or
Actually, all other means abdominal examination was normal, and USG abdomen was also done. We did a CT thorax also. We need to rule out any local causes.
In that case, a paradoxical movement will not be there. Abdominal.
Yes, there was reduced movement. Also, there was a paradoxical movement on the diaphragm. And yes, and we did a fluoroscopy to confirm it, and also a fluoroscopy, basically ultrasound. They read. Yes, we did fluoroscopy as a part of an evaluation. Yes, completions.
By clinical examination, you can find out this unilateral paralysis of diaphragm. What's that sign called?
My question is
Lytton sign.
My question is where was the neurological localization?
The C3, C4, C4, C5, C5, C6 levels.
So it must be a reversible thing.
Probably.
So what it could be? A reversible thing. So because there is a cervical canal stenosis that is not usually it's not a reversible condition.
Okay. Maybe some neuropraxia.
So if it is a reversible thing, the patient is again likely to develop the same thing in the future.
Yes. So probably could be a neuropraxia.
Yeah. No. Yes, my student, yeah. So can I talk?
You can make comment.
Yeah, I can make.
Consider your question or answer.
Then I'll quit. Yeah, exactly. This patient is having, as she said, she is admitted through the emergency department and having severe dyspnea at that time. And when we examine, we find out clearly that it is a bilateral diaphragm palsy. During clinically also, and it is confirmed by ultrasound and by fluoroscopy also. And maybe in cervical canal stenosis, it can occur as transient. If it is not a fully obstructed, fully compressed, it can occur as a transient bilateral diaphragm palsy. It gets relieved and sometimes it may come back. And on progression, it may be, as sir said, bilateral quadriplegia and diaphragm palsy can occur in due course also.
No, do not consider this as transient. This is a serious issue.
No, this is serious. As far as the diaphragm palsy, yeah, exactly. No, we have consulted the neurology and he is under follow-up. This case came recently only. Now he is somewhat okay. No. Still, no.
Can it be tuberculosis?
Tuberculosis can also happen, but less likely. But elevated diaphragm, we have paradoxical.
At that point, it can be an extra vertebral lesion extending into the canal. Is an tuberculosis
Infective, that can also, but then that will be.
I am saying that there is a patient in the hospital at present
But usually it will have but he will be presenting with signs of meningitis, TB meningitis. Yeah, but that signs. That's.
Okay,
Thanks.
With that, we have come to the end of our 8 case presentations of the day, the results for which will be said shortly after the CPC session. But before we end the session, I request the judges to give their valuable comments regarding our 8 case presentations. Anthony, sir.
Actually, I was not told that I must give comment at the end, so I did not note down the points regarding each candidate separately. In general, it was a very good presentation, excellent cases, well worked out. Only comment I would like to say is when you see a case, there has to be a clinical diagnosis based upon which you proceed. Sometimes I found that straight ahead you have gone for investigations and then proceeded. Maybe because they were worked out in some other hospital and they have already done CT scan and so on and sent to you the reference letter so that you didn't bother about the provisional diagnosis. Otherwise, it was all well worked out cases, well discussed. Thank you.
So we have evaluated 8 cases and all of them were good cases, very good cases, and most of them presented well also. Discussion part also, we appreciate the discussion part, well prepared. Now only thing is that we have few extra pulmonary cases going into the respiratory system. That is a very good sign because we are looking at a different system also which can involve respiratory system. So as sir has pointed out, many cases will be worked up outside and patient is coming with a CT scan or an MRI, then we make a diagnosis. But there are areas where we can definitely do intervention like a foreign body case, that paragonemias, all those cases the students and their faculty should think about that, then only we will pick it up. So that way the teaching as well as learning experience is in a good progression mode. That is what I want to say. Only one suggestion is you could have taken all the 21 cases for presentation because we have given enough and more time. Even for discussion, it is not completed. So 7 minutes or 8 minutes presentation and 5 minutes discussion, 30 minutes for a case means we could have taken more cases, isn't it? No, enough time is there because I think all cases balanced time was there. Then teachers, all the teachers behind the students should tell the students to write case report. Writing case report is an experience for publication in the future. They should start writing the case report, then research paper they can write. So it begins with case reports. And case report, it is easy for publication now. So very good cases will be taken even in international journals, or we can present in our local journal or national journal. So at least students should be motivated to write the case. Then only there will be some progress in that. So they will be motivated to see more good cases, present more cases, and writing skill also is very important. So I request all the teachers to give importance to that aspect also. Thank you very much.
Thank you, judges. With that, we have come to the end of our case discussion. Next, we have the clinical pathological correlation session moderated by Dr. N.S. Davis. I invite sir.
Good afternoon. Now after the case presentations, let us go to the clinical pathological correlation discussion with our Dr. Murali. Welcome to the stage. He is the associate professor at Government Medical College, Trichur. Dr. Binoj the radiologist from Amal Institute of Medical Sciences. Please come to the stage, please. Dr. Geeta, pathologist from Amal Institute of Medical Sciences. And myself, Dr. Ennis Davis from Pulmonary Medicine Department of Amala. I invite our presenter, my own PG, Dr. Nishant, to take up the mic.
Respected professors, teachers, and my dear friends, today I will be starting with the history of my clinicopathological correlation case. So, a 65-year-old male patient with comorbidities of hypertension, type 2 diabetes, hypothyroidism, dyslipidemia, chronic kidney disease, which was due to diabetic kidney disease, and post-COVID came to a department with complaints of shortness of breath on exertion for the past 3 months, intermittent dry cough for 2 months, generalized tiredness 2 months, numbness of both hands and legs 2 months, edema of feet 2 months, and weight loss for 2 months. So, coming to the history of present illness, so the shortness of breath was progressive in nature. Initially, it was MMRC grade 2 to grade 3, which aggravated on exertion and on lying down and relieved on taking rest, and there was no diurnal or seasonal variation. Dry cough, it was aggravated on lying down and relieved on sitting posture, and it was more during night. There was no seasonal variation. Now, generalized weakness, it was associated with loss of weight and decrease in appetite. Now, numbness of both hands and feet and edema feet was there, which was more in bilateral legs. There was pin and needle or glove stocking type of neuropathy, and there was spitting edema present. And personal history, he was not a smoker or an alcoholic. He was a father in a church, and there was no history suggestive of bronchial asthma or nasobronchial allergy. There was no history of any exposure to pets at home. Relevant past history, which I mentioned, I will be telling about the total duration. He was a diabetic mellitus patient for the past 25 years, now currently on insulin, then hypertensive for the past 10 years, diabetic kidney disease for the past 5 years, the CKD, then hypothyroidism 3 years, and this was a treated case of extrapulmonary tuberculosis in 2014. And he got COVID 3 months back. I will be telling about the COVID history. COVID history, the date of onset of symptoms was 21st May 2021. He was categorized as category B moderate. The date of COVID positivity by rapid antigen test on 23 May 2021, and the date of COVID negativity was not 6 June 2021. Vaccination status at the time of getting COVID, he got only 1 dose of Covishield vaccination, and the date of admission at our center was 16th August 2021. So, coming to the general physical examination.
Excuse me, Dr. Murali, would you like to have some discussion on the history-wise?
Essentially, this patient is non-hypertensive and diabetic with a high history of hypertension, so a lot of comorbidities, who presented with breathlessness of recent onset, which was grade 1 to grade 2, grade 3 also. So at this point of time, I would consider the cause of breathlessness as cardiac breathlessness because cardiac failure, because the patient has got some of orthopnea as well as there are peripheral edema is also there. So that is the only thing. And the next thing, I think I have to discuss the clinical history only now. Yeah. And nothing much from the history. So chronic, a diabetic for quite a long time and hypertensive can very well develop cardiac failure. That is the only condition which I suspect as of now.
Can you think something related to COVID?
COVID, this might have, included the COVID and COVID sequelae. Like the patient had relatively asymptomatic COVID 3 months back, yet still the patient can have respiratory affection like bronchiolitis as well as simple asthma itself can, just a VC disorder can develop, and also an episode of pulmonary embolism, being a thrombotic state pulmonary embolism also may be considered at this point of time because it's of a recent onset.
Right. So here, yeah, take your seat. some psychological involvement with depression and post-traumatic
Yeah,
stress.
but mostly there is an inspiratory deep sighing episodes, but here there is definitely orthopnea.
But here they were having the
Edema.
pedal edema,
Yes.
some
Yeah, we have we
progressive dyspnea.
Pardon?
It was a progressive dyspnea.
Progressive dyspnea, we have
Post-traumatic stress disorders, they usually have some panic attacks, some off and on phenomenon. Here it was a progressive kind of shortness of breath with a cough. Okay, with a lot of comorbidities like diabetes, hypertension, CKD, hypothyroidism, old PTB, tubercle lymph node, and having COVID as a cherry on an ice cream. Everything anything can go for this cough and shortness of breath. Diabetes can go for it, hypertension can go for it, hypothyroidism can go for it, right? Dyslipidemia can go for it, and the CKD can go for it with some kind of edema. And as yes, rightly pointed out, post-COVID any thromboembolism phenomenon or the what you call sequelae of COVID, anything can be related. It's a very vast area if you look at the history of this old man. Most of the comorbidities can go for this dyspnea and cough for the last 2 months, right? Yeah. Okay, thank you, Murli.
So now coming to the general physical examination, patient was conscious, cooperative oriented. Patient was having clubbing of grade 2. There was right axillary lymph node swelling. There was bilateral pedal edema which was spitting type. There was hyperpigmented dry scaly skin, and there was hypertrichosis also, and there was dryness of extremities. The vitals were the heart rate was 87 per minute. The blood pressure was 110/70 measured in the right arm in sitting position, and respiratory rate 22 per minute, and the saturation was 92% on room air. Now this is a diagram of his forearm which represents that there is hyperpigmentation along with hypertrichosis, and there is a dry scaly skin. And coming to the relevant chest examination findings, there were findings suggestive of bilateral effusion. There was the stony dull note on percussion on the bilateral lower zone areas, infrascapular areas, and there was decreased breath sound intensity which was also present in infrascapular, infraaxillary areas bilaterally.
No pallor nose, clubbing, no. Grade 2 was there. Yeah. So on clinical examination, he was having grade 2 clubbing and pedal edema and bilateral effusion, signs of bilateral effusion. Dr. Murli, please.
Yes. So about the clinical examination, the major points are clubbing and right axillary lymph node. And the vitals, you can see that there was the saturation was 92%. So two things, clubbing plus lymph node, we usually consider malignancy as first possibility, especially the lung malignancy as a first possibility. And desaturation with the clubbing, we would consider interstitial lung disease. So these are the two things. But he said there is features of bilateral pleural effusion. So pleural effusion plus clubbing, again, pleural effusion plus clubbing, two diagnoses. One is the empyema, the other one is malignancy. And pleural effusion plus clubbing plus lymph node, again going for malignancy. So that is a possibility which I consider at this point of time. Not much from the then there is hyperpigmentation, dry scale is in hypertrichosis, maybe a paraneoplastic. If that is the case, then it can be considered as a paraneoplastic as a part of paraneoplastic syndrome. So there could be a background illness like diabetes, diabetic kidney disease, edema, then a COVID and post-COVID sequelae, and on top of that there could be a malignant pathology which is presenting or worsening the pre-existing condition. That is what I feel like.
Yeah, that's well pointed out. Because the clinical examination was mainly showing the clubbing, axillary lymph node, then pedal edema, and some hyperpigmentation, hypertrichosis. I didn't recognize this during the time of presentation. This is basically retrospectively we have taken it. But actually he has got real hypertrichosis. By the photo you can you can appreciate it. So, and with the bilateral effusion, if there was no effusion, I would have managed it as an OP case, like post-COVID sequelae with, as Dr. Murali was mentioning about some fibrosis or cardiac failure or those kind of, and hypothyroidism itself can cause some pedal edema. So that way, I would have given some antibiotics or some symptomatics and have get him out of the OP room. But since the X-ray, can you show the X-ray, please? Yeah, Dr. Binoj, can you take up the mic?
There is bilateral pleural effusion. Apart from that, there was no significant positive findings.
Coronary calcification is there.
Coronary calcification is also there.
What about a pulmonary trunk? Can you call it as prominent or dilated or?
It's almost of normal size.
Normal size. Does he have some abrupt cutoff of that right descending branch of pulmonary trunk with some effusion? Because we are seeing a possibility of a pulmonary thrombolism, as Dr. Murali was mentioning about post-COVID period.
Seems some enlargement with abrupt cutoff, but we have to see the CT for making the right decision.
But still, we have to suspect, right? A prominent pulmonary trunk with some cutoff with effusion.
Okay.
I think post-COVID period, I think we have to suspect embolism in this case. Okay, can you proceed? But ideally, as Dr. Binoj was mentioning, like it needs either the echo to see the right pressures, and also the D-dimer levels, or you need a CTPA for exact diagnosis of a thromboembolism.
Now coming to the initial workup of the patient, we did a CBC, that is hemoglobin was 11.2. The total count was 7690 with a neutrophil predominant 78.2 with a eosinophil count 2, monocyte 2.5 and a basophil of 0.3. So the significant finding was an elevated ESR of 68 millimeter per hour. Serum creatinine is elevated more than 1.5, 1.7 milligram per deciliter. Blood urea is elevated 108, and total proteins is less. We can see that 6.3 gram per deciliter. There is hypoproteinemia for the patient. Albumin is 3.4, globulin 2.9, and A by G is 1.2. Total bilirubin and direct bilirubin is okay. SGOT, PT, the liver enzymes are fair enough. Then TSH is high elevated, so it is a patient is a case of hypothyroidism, and the free kappa light chain and the free lambda light chain, they are both elevated. We can see the normal values which has been written in the brackets. LDH is also elevated 297. NT pro BNP, it is also elevated 2258. D-dimer, a post-COVID case we are working up, D-dimer is 1735. Urine albumin is 2+, so the patient is having a CKD disease. Then all the viral markers were negative, and the serum VEGF, there is a vascular endothelial growth factor levels, were elevated, which was assessed by sending the blood sample with the help of our hematologist to USA.
I think, previous one. As a previous workup, I think we have done up till here only. Am I right? I think we have done it till here only. Routine blood, biochemistry, thyroid values. Yeah, up to TSH. Later, the D-dimer we might have done, and NT-proBNP we might have done. And then later the things actually evolved from the working, during the working diagnosis. What do you feel like from here, the thyroid, Dr. Murali, from here at least?
Up to that, up to thyroid. Okay.
Up to thyroid,
the hemoglobin is okay for an Indian. The differential diagnosis, I consider it as a slight monocytosis. very slight, 2.5. This can happen in acute as well as chronic infections and other inflammatory conditions as well, ranging from tuberculosis to lymphoma. So, not much of a specific finding. Definitely the renal parameters are slightly elevated, and albumin is only 3.4 gram. Otherwise, the TSH is elevated, and that suggests an uncontrolled hypothyroidism, not a well-controlled hypothyroidism, I guess. Otherwise, the routine examination, biochemical as well as hematological examination is within normal limits. The next part is free kappa light chain, lambda light chain. So definitely they are elevated. So basically this patient has a light chain disease. So we have to sort out which is which. That is the thing which we need to do. So from the pulmonologist point of view, the patient has got a bilateral pleural effusion, and we need to look into the pleural fluid characteristics to whether it is a transidative or whether it is an exudative. That is the first step that I want to do. D-dimer can be elevated in the post-COVID scenario, and that is a non-specific thing, and that is not at all diagnostic at this point of time. So if it were negative, then if it was negative, then we could have suggested that the patient doesn't have any pulmonary embolism, but it cannot rule in pulmonary embolism. Urine albumin, you can see that there is 2+, maybe a diabetic kidney disease, and the viral markers are negative. The striking feature is that the vascular endothelial growth factor. Vascular endothelial growth factor has been involved in many physiological processes in the body, ranging from wound healing and development of pulmonary hypertension, and so many other even in malignancies, it is elevated, and even it is associated with malignancy, that shows a very poor prognosis. So it's a non-specific thing, but it may be associated with the particular patient's clinical condition at times. So elevated serum vascular endothelial growth factor is an important finding in this patient. I don't know why this was done. Maybe for some specific reason later on, which was found in some other clinical examination or something.
This case was seen by a multidisciplinary team, including a physician, nephrologist, and a hematologist. So that's why I told you, like this much investigation was by me. Then what was disturbing me was the D-dimer and NT-proBNP. So I needed the help of.
I mentioned the NT-proBNP. NT-proBNP is a marker of the cardiac. This thing status and cardiac failure. Yeah. So as I earlier said, the patient might be having a cardiac failure. Probably let's say the cardiac failure because of the chronic nature of the diabetes, probably an uncontrolled diabetes. But diabetic cardiomyopathy can occur, and also hypertensive. So this patient can very well have a cardiac failure. So clinically speaking, the N-terminal proBNP can be related to cardiac failure. So that can explain to some extent explain the symptoms as well.
Yeah, but still the effusion was disturbing me. At this point, whether Dr. Murali, what I want to know from you is, will you put a needle?
Yeah, definitely. I will put a needle for diagnosis. A diagnostic tap in because it's a bilateral pleural effusion. First step is to determine whether the pleural effusion is exudate or transudate. So for that, I would like, and my presumption is that it's a transudative pleural effusion. So I will take only few ml of the fluid for determine whether it is transudate or an exudate.
Yeah, that's what I actually. We have gone through the pure lights criteria, and one of the value was pointing towards exudate. So then the next point of the thought was whether to go for an invasive kind of thoracoscopy or whether you just need a fluid for analysis.
At present, I don't think that the pathology is inside the pleural cavity, so I won't go with a thoracoscopy or a more invasive procedures, because from the lights criteria as well, I have calculated the lights criteria and it doesn't show that it is an exudate. All the parameters are against an exudate.
So if you have a doubt, I think you can have a left lateral view and see whether the thickness of the fluid is more than 1 centimeter or 10 millimeter. then anyway you can do a diagnostic thoracentesis. But here anyway the patient was having lot of comorbidities, whether we are missing few exudative causes just because he is having cardiac failure, that was the question.
Okay, the ratios are not in accordance with the Light's criteria, so I do not consider both the ratios of protein as well as the LDH are not in favor of a exudative pleural effusion, and also the albumin gradient also doesn't suggest it was calculated to be around 1.9. So anything which is more than 1.9 is not exudate. So that also was not suggestive of an exudate. So I consider this pleural effusion as a translative pleural effusion. I would not be going for a invasive thoracoscopy in this patient.
But here the nephrologist told like he's suspecting some amyloidosis also. What's your opinion? Because yeah,
amyloidosis is a light chain. In presence of light chain, yes, definitely amyloidosis can be. So I couldn't localize any features of amyloidosis except for the cardiac failure, which can be explained by the other comorbidities. So there were no other thing except for the peripheral neuropathy, which may be a part of the amyloidosis. Pleural biopsy may not be yielding, rather than a sural nerve biopsy would be better in this particular clinical setting. So sural nerve biopsy would have given a better diagnosis on the light chain deposition than the pleura. That is what I feel.
Which biopsy?
Sural nerve biopsy.
Sural
this
nerve.
patient has numbness of the both the lower limb and
some peripheral neuropathy. Yeah, right. Okay. Do you have the echo findings? Yeah.
Patient has a right. There were no regional wall motion abnormalities. Patient has good systolic function, but definitely there was a diastolic dysfunction. That can explain the elevated probe BNP as well. And mild to moderate mitral regurgitation, mild tricuspid regurgitation, and mild pulmonary hypertension. So pulmonary hypertension, definitely mild pulmonary hypertension is there. Anyway, that was not quantified. It is said as mild, and mild TR can be attributed to the pulmonary hypertension as well. So it must be significant pulmonary hypertension. So why should this patient develop pulmonary hypertension? So again, going back to the COVID history, the patient can develop again embolic episodes, and that can precipitate a thromboembolic pulmonary hypertension. That could be one of the reasons. I didn't get any definite parenchymal lesions in the X-ray, at least. So that the parenchymal, I mean the core pulmonary, if you say that it is due to a lung disease, I don't think it is due to a lung disease. Maybe pulmonary vascular disease, definitely, but lung disease may not be the reason for the mild pulmonary hypertension. But the chronic diastolic dysfunction also can cause the pulmonary hypertension to a lesser extent. So one of the common causes of the pulmonary hypertension is chronic left-sided dysfunction. So this patient may have chronic left-sided dysfunction that might have precipitated pulmonary hypertension at this point of time. That's what I feel.
Yeah, but still with a lot of comorbidities, we were having some hiccups. Whether the patient is having some exudative kind of effusion, in the sense some other reason for bilateral effusion. So in case of as you have told, if it's only cardiac failure, there shouldn't be any fever, or there shouldn't be so much raised ESR, and there shouldn't be some atypical features of effusion, and they were not, which is not improving with the diuretics. So the nephrologist was thinking in an alternative way. We were thinking in our own way, and the hematologist thinking in their own way. So that's why how the other reports also have come about the light chains, VEGF, and the nephrologists. All were investigating in the parallel line. So we went ahead with ultrasound, abdomen and thorax.
Ultrasound, yes.
Ultrasound abdomen shows mild hepatomegaly, borderline splenomegaly. So, and along with cholelithiasis and sludge and bilateral mild renal parenchymal changes, which can be explained by the CKD of this patient. So there was minimal ascites, minimal diffuse thickening of the colon, descending and sigmoid, and there were inflammatory changes. So here there is organomegaly of liver and spleen, and there is minimal ascites.
Okay, this patient has minimal ascites as well. So not only in the pleura, the peritoneum is also involved. I mean, not the peritoneum. There is fluid in the peritoneum. I consider this as a part of the generalized edema the patient has.
Yeah, what about then borderline splenomegaly?
Yeah, we are coming to that. There is hepatosplenomegaly. So all, and also there is a lymph node. So all the differential diagnosis of a hepatosplenomegaly, starting from the chronic infection like malaria, Kala-Azar, especially when there is a hyperpigmentation, Kala-Azar, and also lymphoproliferative disorders also should be considered. So I would consider lymphoproliferative disorders at this point of time because the patient has got hepatosplenomegaly and a lymph node, and also not a single lymph node. There was multiple.
Both axilla. Both axilla.
Both axilla as well as the mediastinum was involved. Though it was okay. So so there is a generalized lymphadenopathy and hepatosplenomegaly. The first diagnosis I would consider is a lymphoproliferative disorder like a lymphoma or other.
High ESR also you can think about that. Okay. So that's why we have proceeded with the thoracoscopy. We expected something to be seen, but we could give some symptomatic improvement with by draining of around 1,500 ml of straw-colored fluid, and there was few mucus elevation. We were not seeing any pathology things. So we were just seeing some mucosal elevation which was seen over the costal pleura, which we biopsied and then put a chest tube and we came out. So the histopathological examination of that elevation, I think the mucus, we have only the words like vascular hyperplasia was seen. So usually I don't look into this vascular hyperplasia, which later I could make out each words from the pathology is important.
Vascular hyperplasia.
Yeah. She may mention about that. Sorry, we disturbed you, right?
Sir.
From the order.
Sir, HP was suggestive of chronic inflammation, and there was vascular proliferation and there was mesothelial hyperplasia.
Yeah.
So this was a report of pleural biopsy.
Yeah, Dr. Geeta, can you just explain what is the real core of this chronic inflammation, vascular proliferation, mesothelial hyperplasia in a scenario like this?
All these findings, as a pathologist point of view, chronic inflammation and vascular proliferation and mesothelial hyperplasia could be seen in any reactive pathology, like any chronic inflammatory state. For that matter, a chronic effusion, it is just a reactive change. It doesn't point towards any specific pathology. Any chronic irritation can lead to the mesothelial hyperplasia and vascular proliferation. And here we have just mentioned it was just a chronic inflammatory infiltrate. There were no granulomas, so again, it doesn't point to a specific pathology. It was just a reactive.
Yeah, that's the way we also took it. Like it's not a specific one. And I was depressed without getting any biopsy diagnosis. So this usual we call it as inconclusive, but this was not inconclusive. When the case was, it's coming to our. Pardon? Appearance was normal. Only. Nothing. That's why I expected a few things to be biopsied, but only what I saw was a mucosal elevation. Whether that is significant or not, I was not knowing it. I just biopsied it. Rest all the pleura, costal, visceral, the diaphragmatic, everything was normal except for the 1,500 ml of straw-colored fluid which drained out.
That is mesothelial.
Mesothelial elevation, not mucosal.
Yeah, probably.
Can we consider asbestosis at this stage?
Had it been a case of asbestosis, we would have definitely seen the tissue reaction towards it, but which was evidently absent. And we would also, with this histology, I wouldn't consider we would get more of foreign body giant cell reaction. We could sometimes make out the crystalline structures on a polarized microscope. So with this histology, I wouldn't consider it.
I consider this pathological findings to correlate with the vascular endothelial growth factor, which is a generalized phenomenon. So this vascular proliferation may be related to the vascular. See, from the clinical point of view, I consider the vascular endothelial growth factor elevation may be associated with vascular proliferation. Is that so? Is that right?
This VEGF estimation is not a very commonly done.
Yeah. Okay.
So that's what actually we were not satisfied with the report. Sorry to tell that, because it's actually once we get the report like this, we are nowhere again. So yeah, but I should have a adequate pathology inside. So
But
that's why
I don't think there is any pathology inside the
if there was an adequate pathology for biopsies, I would have done that. But I was having only a what you call a small 2 millimeter size, some elevated tissue which I have biopsied for. I preferred just taking that biopsy and coming out rather than just coming out. So that way, it's sorry, it's not your fault. It's not my fault or anyone's fault. So sometimes we may get report after all this investigation, this kind of. Actually, you may in your deep mind you may have some grudge for the pathologists. Sorry to tell that, but still, since I don't have anything else to biopsy, and also, I know what I feel.
That is done. That is done.
Yeah, that's done.
That will come. That will come.
This was a transudatory pleural
lymph node.
effusion. This was a transudatory pleural effusion, and there was evidence that means you are suspecting cardiac problems. There is chronic renal disease also there. So that's a transudate. So why should you go for thoracoscopy?
Yeah, that's what basically that's a good question. Actually, that's what I was thinking twice before going for a thoracoscopy. We were getting it as a transudative, but the nephrologist didn't stop me there, telling like the amyloidosis has to be ruled out. It's an unusual cause for renal failure. So I was thinking about either renal biopsy, or if you can biopsy from the pleura, that may be enough for, especially to rule out amyloidosis. That's why I was asking Murali whether he keeps a diagnosis of amyloidosis in this case. And the second part is the effusion. 1,500 ml of fluid. It's on one side, left side. So that made me thinking of getting in. Then the third part, the lymph node, which Dr. Shahjan was mentioning about, it's usually whether that lymph node was significant or not, we never know. He had hypertrichosis and all the sweat inside, and I don't know whether it's a local infection which has gone for that lymph node on either side. Not mediastinal. There is no mediastinal lymph node, only this axial lymph node, which is around 0.5 to 1 centimeter, rubbery, which is moving. Doesn't feel me like it's a pathological lymph node.
Which is a better site to diagnose amyloidosis when you suspect amyloidosis?
So the systemic amyloidosis, usually we get rectal biopsies and biopsies of the tongue.
Lip biopsies also.
Yeah, oral cavity and lip biopsies.
Do our nephrologists do that rectal biopsy for?
Once in a while we have got, but once even we have got a amyloidosis in a lung biopsy. It was your case itself, I think.
I don't remember. Yeah, I remember. You have special stains also for that, right?
Yes, it can be suspected in the routine stain, and when we suspect amyloidosis, we do a special stain called Congo red, and we view under a polarized microscope to see apple green birefringence.
Birefringence.
So can you just show the CT for? Yeah.
This is a CT, the only cut which is available.
You will give some time for Binoj to discuss about the CT chest. You come with your slides.
Yes.
Yes.
I included only the CT images. None of the lesions were showing PET uptake, FTG uptake. Okay. It's a bone window image of the skull. You can see the sclerosis of the calvarium. Usually we can see some minimal amount of diploic space. you can see on comparing with the normal one, there is increased density for the bones. Okay, second slide please. Here is the axial CT section of the neck. On both sides, on the side of the vessels, adjacent to the vessels, you can see some prominent cervical lymph nodes. That lymph nodes are enhancing. On right side, it is pointed with an arrow. And there is also diffuse subcutaneous edema. Okay, next slide. The edema is more evident in this slide. There is opacification of the subcutaneous fat. Here it is that's right please. It's a axial section at the level of the mid chest. Here you can see moderate pleural effusion bilaterally, and also there are some mediastinal nodes, right paratracheal nodes. The short axis size of the nodes will be around 7 to 8 millimeter, not more than 1 centimeter. That is pointed with an arrow. Next slide please. Here it is lung window image of the mid chest showing bilateral pleural effusion, and in the lung window there is some ground glassing bilaterally. Next slide please. Here it is a coronal image of the abdomen. On the right side you can see hepatomegaly. Spleen is of normal size, and some perirenal fat stranding is there, perinephric fat stranding is there. Next slide. Here axial CT slide, axial CT at the level of the pancreas. You can see a small cystic area at the region of the body of the pancreas and few calcifications. These calcifications may denote chronic calcific pancreatitis. There is some opacification of the retroperitoneal fat. Next slide. Axial CT at the level of the inguinal region, at the level of the lower abdomen, pelvis region. Here you can see enlarged external iliac lymph nodes. It is marked on the right side. There is also an enlarged lymph node on the left side also. Edema is also evident. Subcutaneous edema is also evident in this image. Next slide. It's a bone window image of the pelvis. Here we can see some sclerotic areas in the bilateral iliac bones. Next slide. Okay, leave it. So in all together, the findings are sclerosis of the calvarium, then some small sclerotic lesions in the pelvic bones, bilateral pleural effusion, some ground glassing in the bilateral lungs, hepatomegaly, and diffuse generalized lymphadenopathy. Along with that, there are some few findings in the pancreas, a small cyst in the pancreas, and some calcifications. These pancreatic findings may denote chronic calcific pancreatitis.
Can you just point out why these diagnoses came from your CT?
It is not from not for the whole CT. It is for the I included it for the generalized sclerosis. First we will consider malignancy, then myelofibrosis, mastocytosis, sickle cell disease, Paget disease, renal osteodystrophy, fluorosis. From the clinical discussion, it was pointed out that the first possibility is malignancy they are considering.
Yeah, I was just knowing about the other things. Okay, good.
Myelofibrosis is also not a bad option, but we get a massive splenomegaly rather than a moderate splenomegaly, hepatosplenomegaly.
Okay, thank you, Dr. Binoj. Thank you, Dr. Binoj. Can we come to our point? PowerPoint എടുക്കുന്നു. just show any slides you have missed or not.
No. Okay. So we have discussed, so this patient has an axillary lymph node that is going to tell you the diagnosis. That is what I understand.
Right.
So this patient, the clinical background is again going back to our clinical background. He is a 65-year-old male, hypertensive, diabetic, having hyperthyroidism, dyslipidemia, diabetic kidney disease, all sorts of comorbidities along with the post-COVID status. There is bilateral peripheral neuropathy for upper limb and lower limb, and weight loss and anorexia, shortness of breath and edema. The symptoms were there for 3 months, intermittent cough for 2 months, generalized tiredness, numbness, almost that this coinciding with the COVID-19 infection as well, incidentally. So we consider the possibility of cardiac failure, renal failure, that will describe the edema as well as the breathlessness, or it can be due to a long COVID hold, or diabetic kidney disease, diabetic nephropathy, weight loss, anorexia can be due to an uncontrolled diabetes, chronic infections like TB, fungi, malignancy, etc. Here malignancy is the top of the list. Is it TB? The patient had a history of treatment for extrapulmonary TB, lymph node TB, 2014. Altogether, is it tuberculosis? This can be tuberculosis, but there are some odd points. The symptoms are not in accordance with the tuberculosis. Physical examination, there is pitting pedal edema. It can very well seen in diabetic kidney disease, or is it a fluid overload condition like cardiac failure? The patient has all the comorbidities to develop cardiac failure. Hyperpigmented, dry, scaly skin, more in extremities. This can be seen in hypothyroidism as well as diabetic dermopathy also. Diabetic dermopathy can develop after 10 or 15 years of diabetes. The patient has got clubbing. Clubbing, I couldn't fit into any respiratory condition for this particular patient. I was considering interstitial lung disease, but there are no interstitial lung disease. Clubbing plus lymph node, clubbing plus pleural effusion, everything can go in for a malignancy. But from the CT which I have seen, only one cut was given to me. That doesn't show any mass lesion or signs of malignancy. And our radiologist also had a detailed discussion of the various parts of the abdomen as well as the chest, and doesn't show any definite evidence except for the lymph nodes. Dermatological manifestation, as a recent onset hyperpigmentation and hypertrichosis. That could be a paraneoplastic syndrome, or it can be a drug-induced, but there is no history of a drug intake like phenytoin, cyclosporin, androgenic steroids, or minoxidil. If the patient is using minoxidil, if accidentally falls to some part of the body, that can be hirsutism, but that is not the case here. So I consider this as a paraneoplastic syndrome. Hepatosplenomegaly, chronic liver disease with a portal hypertension, that is one reason, but no other features of chronic liver disease, no stigmata of chronic liver disease. The biochemistry also doesn't show any features of chronic liver disease. Infections, malaria, all are out because here it is not an endemic area. Still, we can consider malaria as there is hepatosplenomegaly. Enteric fever is also, the clinical picture is not suggestive of enteric fever. Lymphoproliferative disorders, patient can very well be lymphoproliferative disorder with lymphoma. Ultrasound, minimal ascites, and a thickening, probably an inflammatory change. Can it be tuberculosis? It can very well be tuberculosis, but mostly that is seen in the ileocecal junction, not in the descending colon. The descending colon we usually suggests malignancy. Then patient has got bilateral pleural effusion. Bilateral pleural effusion we have already discussed in detail, and I don't think that it's a exudative effusion. It's a transulative effusion by all means. And the patient has cardiac failure suggested by elevated pro-BNP, and this can happen in volume overload conditions as well, or other volume overload conditions like renal failure as well. Pleural biopsy has been discussed in detail. The description given in the case was the non-FDG avid lymph nodes in the mediastinum. That was the description given. Non-FDG avid mediastinal lymph nodes can be seen in case of benign lesions and also in healed tuberculosis lesion. So usually the FTG PET is not used to diagnose these things, but it can be used as a in the follow-up to determine whether the disease is progressing or not. Some of the cases of case series say that Castleman disease also can have non-FDG avid lymph nodes. Echo, there is pulmonary hypertension, diastolic dysfunction, which can explain the this thing.
Cardiac failure.
Cardiac failure. N-terminal pro-BNP, cardiac failure. N-terminal pro-peptide type 1 collagen. This suggests bone turnover. So our radiologist showed a case of sclerosis of the bone, generalized sclerosis of the skull. So in such cases, we have to target this molecule, and this has to be done instead of N-terminal pro-BNP. Now coming to the kappa and lambda chain. See, this patient essentially has a light chain disease. So we have to determine which type of light chain disease this patient has. Definitely the levels are pretty high, and an elevated ratio of kappa and lambda to free light chains indicates a monoclonal, kappa free light chain, monoclonal. An abnormally low kappa lambda ratio, as in this case, you can see that the ratio is 1.79. 1.7, the reference value is given as the 1.65 to 0.26. So this sort of ratio can be seen in multiple myeloma, Waldenstrom's macroglobulinemia, smoldering multiple myeloma, monoclonal gammopathy of undetermined significance. We were talking about the other, the amyloidosis and all. In that case, this will not be the the biochemical picture.
Excuse me, sir. Can I interrupt?
Yes, please.
Now here, the free kappa and the free lambda levels are given, and also the kappa lambda ratio.
Yeah. Yes, yes.
Now we have both elevation of both kappa as well as lambda.
Yeah.
So that means it indicates a polyclonal disease.
Polyclonal disease.
So it could be seen in an inflammatory pathology, any infections, chronic infections like that. To label it as plasma cell disorder like myeloma or monoclonal gammopathy, we should have a kappa lambda light chain restriction. Either only kappa will be elevated or just lambda will be elevated. So here the kappa lambda ratio, that is 1.179, is within the normal range.
Okay.
Both are raised, so the ratio may be normal.
Yes.
Now the abnormal finding of vascular endothelial growth factor, which can be seen in many conditions, including malignancies, and when it is elevated, that suggests a bad prognosis to that malignancy. But so many other conditions can be it can be elevated, including diabetic retinopathy, polyneuropathy, psoriasis, arthritis, so many other conditions.
And this has been sent to outside lab, not in our lab, I think.
Yeah.
Lalpath lab. Yes.
So many functions for the vascular endothelial growth factor, including metastasis. So this patient has some of the classic, clinical features with all the comorbidities with the polyneuropathy, hyperpigmented hypertrichosis, pulmonary hypertension, clubbing, lymph nodes, mediastinal and axillary lymph nodes, hepatosplenomegaly, monoclonal light chain kappa and lambda, elevated VEGF, and bilateral translative pleural effusion, maybe as a part of generalized edema. So these are the clinical features of this patient. As a generalist, I would like to get the picture of an optic fundus, whether the patient has got a retinopathy or a papillary edema. X-rays of the bone has been shown, not X-ray, the CT of the bones has been shown, and it showed some sclerosis. Peripheral smear and bone marrow study also would be of help in this sort of patients. A nerve conduction study and probably a nerve biopsy also will add on to the diagnosis. As a pulmonologist, a better chest X-ray, HRCT and CECT that has already been shown, spirometry and DLCO, if possible, but I don't think this patient may not be able to do that.
Can you just show me the previous slide?
Yeah.
I think we have done the ECG, we have done the NCS, which was showing a peripheral neuropathy.
Okay.
Peripheral smear and bone marrow study was done.
No mention was
yeah,
given in
I think
that,
they have the
record.
X-ray body lesions we have not found out, and also the optic fundus we have not seen. Yeah.
Okay.
But we have had an ophthalmic checkup in between.
I would.
Okay. So
I
we
would
have
like
not-
to know that whether the patient had papilledema or not.
Okay.
That's all.
Okay, good.
So this patient has all these hypothyroidism, hyperpigmentation, pulmonary hypertension, clubbing, etc. We have already described these things. And among these, the points in the red color has some significance. So when we are dealing with a patient with multiple medical problems, we will try to fit into a particular pattern, whether this pattern is fitting to a particular diagnosis. That is how we have to proceed. So you have to try, we have to try our level best to make a single diagnosis. That is what we are going to do. So this patient has a combination of polyneuropathy, organomegaly, hepatosplenomegaly, and lymphadenopathy, endocrinopathy like hypothyroidism. The light chain disease is there, and skin changes, hirsutism, and this. This will suggest the pattern of a syndrome called the POEM syndrome. That is the same thing. P for polyneuropathy, O for organomegaly, E for endocrinopathy, and monoclonal gammopathy and skin changes. So we may be dealing with the case of POEM syndrome. Basically, it's a paraneoplastic syndrome. So the thing is that madam is going to disclose the diagnosis of the axillary lymph node, which I presume that this is a Castleman disease, because the combination of the other syndromes which we have already discussed, along with the lymph node with the Castleman, so Castleman variant of POEM syndrome. So if you take the criteria for diagnosing POEM syndrome, you have two mandatory criteria. That is,
I think we can come to that point. You're right to the point, don't I? Can you, Dr. Geeta, as a case, this case was interesting to me in different ways, because few words which they use, which are not so interesting for a pulmonologist, like Dr. Murali was mentioning about non-FTG. It has got significance in a few. You were showing some diagnosis of benign Castleman's and all this stuff. And he was mentioning about sclerosis of bone and all. We take it aside once we see all these reports. Sometimes they say like vascular proliferation. We take it like inconclusive kind of. But they all have significance in this case. So that's why you have to hear each and every word of other specialties. That's what I want to mention about this case. Yeah. Dr. Geeta, please.
Good afternoon. So coming to the pathology discussion. So we received the axillary lymph node biopsy. It was a 2 centimeter node. Microscopy showed follicles of varying size. And this is a higher magnification showing that the germinal center of the follicles are atretic and the mantle zone is expanded. Here the lymphocytes are arranged in a concentric manner and we call it onion peel appearance. There is thickening of the vessels, hyalinized vessels, and these vessels are seen piercing into the germinal center, creating a lollipop-like appearance. So as sir has rightly, and this is a reticulin stain showing the prominent vascular proliferation in the lymph node. And as sir has rightly detected from the history and everything, we have diagnosed it as a Castleman disease, hyaline vascular type. So as rightly pointed out in the discussion, this patient had few relevant findings like polyneuropathy, lymph node enlargement, generalized lymph node enlargement, hypothyroidism, indicating an endocrine dysfunction, hyperpigmentation and hypertrichosis, diffuse sclerosis of skull bones and cervical vertebra, and effusions. So are we dealing with a POEM syndrome? So POEM syndrome, it is a paraneoplastic syndrome associated with monoclonal plasma cell disease. It stands for polyneuropathy, organomegaly, endocrinopathy, monoclonal gammopathy, and skin changes. And it is characterized by plasma cell disorder associated with demyelinating peripheral neuropathy. And it is said to be due to a surge of inflammatory and angiogenic mediators, most importantly VEGF. On further evaluation, so the first and foremost, now we have to find out a myeloma for this patient, monoclonal plasma cell disorder, but the M band was negative. There was no light chain restriction. Both kappa as well as lambda was found to be elevated. So that indicates a polyclonal disease. It's not a monoclonal disease. And again, bone marrow examination was done. Aspirate showed 5% plasma cells, and it was polyclonal. We had sent it for a flow cytometry. That also didn't show any light chain restriction. So we don't have monoclonal plasma cell disease. VEGF was sent outside. It was found to be very high. So coming back to the criteria for calling it as POEMS, we have major mandatory criteria, 2 of them, polyneuropathy and monoclonal gammopathy. Other major criteria include Castleman disease, sclerotic bone lesions, VEGF elevation, and minor criteria include organomegaly, extravascular volume overload, endocrinopathy, skin changes, papilledema, and thrombocytosis. So to call it POEMS, we need both major mandatory criteria and any one major criteria and one minor criteria. Our patient has polyneuropathy, all the 3 major criteria and 3 minor criteria like lymphadenopathy, extravascular volume overload, endocrinopathy, and skin changes. So, where are we? So, now recently there has been a concept of Castleman disease variant of POEMS syndrome, which was described by this particular paper in 2014. And these, the cases with 2 mandatory criteria are the standard POEMS syndrome, and those patients without the major mandatory criteria but pathologically diagnosed as Castleman disease could be classified as Castleman variant of POEMS syndrome if they have other POEMS features. So the final diagnosis is Castleman variant of POEMS syndrome. Thank you.
Yeah, that's good. Thank you, Dr. Guido. Yeah, Dr. Murli, please.
While calculating the kappa lambda ratio, this patient has got renal failure. I think it has to be in a different way.
But
I think I don't know that calculation.
Marrow is done, no? There was no
Okay.
plasmacytosis,
Okay.
and even the marrow plasma cells also didn't show monoclonal.
No M band, 5% plasma cells, right? Polyclonal. So, you want to have some more slides? Yeah.
So the POEMS syndrome has been discussed in detail. We have had my teachers telling about POEMS syndrome. So I will be just telling about Castleman disease. It is synonymous angiofollicular lymph node hyperplasia. So what is happening is there is a heterogeneous group of lymphoproliferative disorders that share the common histopathological features which we discussed. The Castleman disease is classified into at least 3 distinct disorders, which is based on the number of regions of enlarged lymph nodes and the presence of absence of human herpes virus 8, which we did in our patient, and it was HHV negative. Now coming to unicentric Castleman disease, it involves 1 or more enlarged lymph nodes in a single region of the body. That is 1 or more enlarged in a single region. So it is unicentric. And the histopathological features will be along a spectrum with hyaline vascular histopathological subtype on one end and the plasmacytic histopathological subtype on the other. And some subtype of patients can have systemic symptoms also. Now, multicentric Castleman disease, which was in our case. So our case was multicentric HHV negative. That is idiopathic multicentric Castleman disease. So what is multicentric? It involves multiple regions of lymphadenopathy. The patients also have systemic inflammatory symptoms, like in our patient. Generalized lymphadenopathy was there, hepatosplenomegaly, organ dysfunction. Okay, not all criteria were met. And the multicentric Castleman disease is further classified according to the presence of human herpes virus 8, HHV associated MCD, and HHV negative, which is also called idiopathic MCD. That is IMCD. Now, the important from our point of view is Castleman disease is associated with a number of malignancies, including non-Hodgkin's lymphoma, Hodgkin's lymphoma, and one of the major criteria to diagnose Poem syndrome, which we discussed, is Castleman disease. Now, Poem syndrome, the rest of the slides have been discussed in detail, so I can conclude my presentation.
So after the pathologist discussion, it is we have to go back to the case and explain whether this diagnosis can explain all the other clinical symptoms and signs of this particular patient. The criteria. Okay, this patient has got a polyneuropathy, hypothyroidism, clubbing, which was considered to be a minor criteria. If you take the minor criteria, there is clubbing, papilledema, etc. And pulmonary hypertension, that can be explained because we had no other cause for the pulmonary hypertension. So pulmonary hypertension, mild to moderate pulmonary hypertension, can be explained with the present condition. Then hepatosplenomegaly very well can be explained. Lymph node enlargement already biopsied. Translative pleural effusion, that as a part of volume overload, there can be generalized edema, ascites, bilateral pleural effusion, so that can also be explained. I have doubt with the monoclonal light chains, so madam has already done. VEGF, definitely, that is a marker of Poem syndrome. And hypertrophism and hyperpigmentation. So all, clinical symptoms and signs have been, explained by the diagnosis. So final diagnosis, Castleman variant of Poems. Thank you.
Thank you, Dr. Murali. Actually, the purpose of this CPC is not the Poem or Castleman or whatever diagnosis you reach it. Basically, you have to have a good rapport with your colleagues. Sometimes when the pulmonary cases arrive at you. For example, the effusion, it all started like the patient is having some lymphoma or some malignancy or some tuberculosis reactivation and all, and landed up in Castleman and Poem. So the take-home message is the whole effusion may not be the pulmonologist domain sometimes. It may have to go to either renal or cardio or endocrinologist or even to a hematologist, as you have seen the case. Thank you for patient listening, and thank you all for so much of time recruited for the CPC. Thank you. Thank you, Murali. Thank you, Vinoj and Dr. Geeta, right?
With that, we have come to the conclusion of our CPC session. Next, we have a valedictory function. I invite Dr. C. Ravindran to announce the prizes of the case presentation.
Good evening. I am entrusted for announcing the results. There were 8 contestants. All were good, very good presentation discussion, and it is very difficult to select 2 as suggested by the organizers. So 6 people will not get praise, but don't get discouraged, because you are also shown good temperament in selecting and presenting good cases. So I will announce the praise. The second praise goes to, any opinion from the audience? Dr. Maria, resident of Government Medical College, Kottayam. Her case was hydropneumothorax in a patient with eosinophilia. That paragonimiasis case. So the coveted first praise goes to Dr. Ramya, resident of Government Medical College, Calicut. Topic, let us not forget the past. So first praise, Dr. Ramya. Second praise, Dr. Maria. Congratulations to the winners as well as all those who have presented.
Thank you, sir. Since this was a hybrid conference, the recipients could not be here, so the prizes would be sent directly. Before we start with the valedictory function, we are giving away our tokens of gratitude. So I invite Dr. C. Ravindran, sir, to present Dr. Shahjahan PS to present it Dr. Binoj Varghese. Next, I invite Dr. Davis Paul to present it to Dr. Geeta CJ. Next, I invite Dr. Kurian Uman to present it to Dr. Murali CP. Finally, I invite Dr. Thomas Vadakan to present it to Dr. Nishant PS. Thank you, sir.
So we want to hear from you, or one or two can talk about our conference. Dr. Suhail.
I would like to congratulate the team APT for conducting this excellent conference. This is a variety conference. I have been following this since the first. I think I participated in the first one, and now the second time I am coming. And each time I'll send my students for presentation also. And I wish all the success and keep going APT. Thank you very much.
Davis Paul, sir.
Yeah, it's, I would congratulate Dr. Thomas and Dr. Jamshir. He has gone. Dr. Jamshir for conducting such a kind of conference in the midst of the Omicron fear. We had a less crowd, but they were able to take out to a hybrid one in the last moment. So that's their, I mean, real hard work. They have to go with all these cases in a short period of time and get the best out of it. I think around 20-21 cases came out, and then almost all the cases were good. And it was a very hard task of the scientific chairman to get out the best 8 out of it, Dr. Davis Paul, sir. And I think Dr. Judo, Dr. Parvati, all female members of the APT were there for not no, even the sorry, yeah, Dr. Unni, Murali, and we were all together again after a period of 3 months, right? After our Palmacon. Yeah, 2 months. So again, it was a good get together with all the Thrissur guys over here. I think it would have been up to mark for you who are who come from outside. Kurian sir, Shahjahan sir, Suhail, and all of Ravindran sir and TPN sir. We are very much grateful to all these people who have come long away and have taken precious Sunday out of their busy schedule to pulmonologists. Thank you very much, and I think it has satisfied your thirst, right? Thank you.
Most of us have attended hundreds of conferences in Kerala, other states, internationally as well. But this conference is unique in the sense that case scenario based concept. and APT is APT is the only club, only respiratory society doing this, and I strongly recommend other regional chess club to conduct these kind of activities, because in CME we know that somebody will come with for topic presentation. We can we can read topics from our, especially during this time, from our home. But these kind of activities is unique. Congrats to all APT tissue team, both males and females. Okay, thank you.
തോമസും ജംഷീറും എൻ്റെ ഈ ഹൈബ്രിഡ് കോൺഫറൻസിൻ്റെ ഉസ്താദുകളായി മാറിയിരിക്കുകയാണ്. ഞങ്ങളൊക്കെ ഇങ്ങനെ പുറകിൽ നിൽക്കുന്നുണ്ടുള്ളൂ. പ്രധാനമായിട്ട് പ്രവർത്തിച്ചത് ഇവരൊക്കെ തന്നെയാണ്. ഉണ്ണിയും ഒക്കെ ഉണ്ടായിരുന്നു കൂടെ. ബാക്കി എല്ലാവരും പുറകിൽ ഇവർ തന്നെയാണ് മുമ്പിൽ നിന്നിരുന്നത്. ഞങ്ങളൊക്കെ ഇങ്ങനെ പുറകിലിങ്ങനെ സപ്പോർട്ട് ചെയ്യണമെന്ന് ഭാവിക്കുന്നേ ഉള്ളൂ. ശരിക്കും ഇത്രയും ഇങ്ങനെ മീൻസ് ഒരു എഗൻസ്റ്റ് ആയിട്ടുള്ള അങ്ങനെ നടത്താൻ പറ്റുമോ ഇല്ലയോ എന്നുള്ള സാഹചര്യത്തിൽ പോലും ധൈര്യമായി മുന്നോട്ട് വന്ന് ഇങ്ങനത്തെ ഒരു പ്രോഗ്രാം എല്ലാവർക്കും ഇൻട്രസ്റ്റിംഗ് ആയിട്ടുള്ള ഒരു കോൺഫറൻസ് നമുക്ക് എല്ലാവർക്കും ഇവർക്കൊരു കൈ കൊടുത്ത് അവരെ ഒന്ന് അഭിനന്ദിക്കാം. ശരി, വളരെ നന്നായി കോൺഫറൻസ് ആണ്. വിചാരിച്ചേക്കാളും ഭംഗിയായി നടന്നു എന്നാണ് ഞാൻ വിചാരിക്കുന്നത്. ഇവിടെയുള്ളതിന് പുറമെ 38-40 40-50 people were online, and all the sessions were very much interesting. It's up to our expectations. So congratulations, very good task, very well conducted. എല്ലാ ക്ലബുകളും ഏറ്റെടുക്കാൻ പറഞ്ഞാലും ഇത് ഞങ്ങൾക്ക് തന്നെ തരണം, മോണോപ്പൊളിയായിട്ട് ഞങ്ങൾക്ക് തന്നെ തരണം. ഓരോ ക്ലബുകൾക്കും വേറെ വേറെ പ്രോഗ്രാംസ് ആയിട്ട് ചെയ്യാമല്ലോ. അത് എല്ലാവരും എടുത്തു കഴിഞ്ഞാൽ അതൊരു ഭംഗികേടാവുമെന്ന് തോന്നുന്നു. അത് പിന്നെ ഇതിൻ്റെ തന്നെ ഒരു ഗ്ലാമർ നഷ്ടപ്പെടുന്ന എനിക്ക് സംശയമുള്ള കാരണം ഓരോ ക്ലബുകൾക്കും ഓരോ തരത്തിലുള്ള കോൺഫറൻസുകൾ നടത്താൻ അത് പേറ്റൻസിക്ക് APCCM അപ്ലൈ ചെയ്തതിന് ശേഷം നമുക്ക് തീരുമാനിക്കാം. കൺഗ്രാജുലേഷൻസ് വൺസ് അഗെയിൻ.
ഓർഗനൈസിംഗ് പ്രസിഡന്റ് എന്ന നിലയ്ക്ക് എനിക്ക് ഒരുപാട് കാര്യങ്ങൾ പറയാനുണ്ടെങ്കിലും കുറച്ച് സമയം കൊണ്ട് പറയാം. ഈ കോൺഫറൻസ് കഴിഞ്ഞ ഇത് 3ാമത്തെ കോൺഫറൻസാണ് ഞാൻ പദവിയിൽ എത്തിയതിന് ശേഷം. ഇതിലെ മെയിൻ സപ്പോർട്ട് എന്ന് പറഞ്ഞാൽ ഞങ്ങളുടെ APTയുടെ മെമ്പേഴ്സ് തന്നെയാണ്. അതിപ്പോൾ സീനിയർ ലീഡർ മുതലായ ഡേവിസ് പോൾ സാർ മുതലേ ഡോക്ടർ എന്നീസ്, ഡോക്ടർ ജൂഡോ, ഡോക്ടർ ഉണ്ണി ശരിക്കും ഇതിൻ്റെ കീ ഫാക്ടർ എന്ന് പറയാം. കാരണം ഇതിൻ്റെ എല്ലാ തുരുപ്പ് ചീട്ട് അറിയുന്ന ഒരാൾ ഉണ്ണിയാണ്. ഉണ്ണിയുടെ പ്രാധാന്യം കുറച്ച് കാണാൻ പറ്റില്ല. കൃഷ്ണകുമാറായാലും ജംഷീർ ആയാലും എല്ലാവരും നമ്മുടെ വെളിപ്പുറത്തുണ്ട്. ഡോക്ടർ പാർവതി ഒരുപാട് ബുദ്ധിമുട്ടിൻ്റെ ഇടയിൽ ഓടി വരാറുണ്ട്. അപ്പോൾ ഇതിന് പുറമെ ഫാർമ സപ്പോർട്ട് എപ്പോഴും APTയുടെ എല്ലാ പ്രോഗ്രാമും അവർ മുന്നിട്ട് വിജയിപ്പിക്കാറുണ്ട്. ഇപ്രാവശ്യവും അവരുടെ സപ്പോർട്ട് വേണ്ട വിധം കിട്ടി ഞങ്ങൾക്ക്. പിന്നെ 2 ഡോക്ടേഴ്സിന് ഞങ്ങൾ കടെടുത്ത് കൊടുക്കുന്നുണ്ട് അമലയിൽ. അവർ രാവിലെ മുതൽ ഇത്രയും നേരം വരെ നമ്മുടെ ഈ പ്രോഗ്രാമുകളെല്ലാം വളരെ നല്ല രീതിയിൽ കമ്പയർ ചെയ്തു. ഇന്നലെയാണ് ഞാൻ അവർക്ക് ഇങ്ങനത്തെ ഒരു ഇൻസ്ട്രക്ഷൻ കൊടുത്തത്. കുറച്ച് സമയം കൊണ്ട് തന്നെ അവരത് ശരിയാക്കി എടുത്തു. അവരെയും പ്രത്യേകം അഭിനന്ദിക്കുന്നു. ഇതിൻ്റെ ഓഡിയോ വിഷ്വൽസ് നന്നായി ചെയ്തു. ടൈമിംഗ് എല്ലാം പെർഫെക്റ്റ് ആയിരുന്നു. എല്ലാ റെക്കോർഡഡ് പ്രസൻറ്റേഷനും കറക്റ്റ് ടൈമിൽ അവരിട്ടു. അത് നന്നായി ഉണ്ടായിരുന്നു. നിങ്ങളും പ്രത്യേക അഭിനന്ദനം അർഹിക്കുന്നു. അരുൺ മോസസ്. പിന്നെ ഇവിടുത്തെ ഫുഡും ആംബിയൻസും നിങ്ങളാണ് പറയേണ്ടത്. ഇവിടെ കഴിഞ്ഞ തവണ നമുക്ക് വളരെ നന്നായി ഫീൽ ചെയ്തുകൊണ്ടാണ് ഇപ്രാവശ്യം ഇത് തന്നെ ചൂസ് ചെയ്തത്. പാർട്ടിസിപ്പേഷൻ വളരെ നന്നായിരുന്നു. APCCMൻ്റെ ഭാഗത്തു നിന്നുള്ള എല്ലാ സപ്പോർട്ടും ഞങ്ങൾക്ക് കിട്ടിയിട്ടുണ്ട്. ഒഫീഷ്യൽ നന്ദി പ്രകടനത്തിന് വേണ്ടി ഞാൻ ജംഷന് കൊടുക്കുന്നത് എൻ്റേതായ ഒരു റീകളക്ഷൻ പറഞ്ഞെന്ന് മാത്രം. പൊതുവെ വി ആർ ഹാപ്പി ടു ഓർഗനൈസ് these kind of academic activities at any time, and APCCM can entrust us in this regard. Thank you.
സാറിനിപ്പോൾ കോൺഫറൻസ് നടത്തി ഓരോ 3 മാസത്തിന് എന്തെങ്കിലും നടത്തിയില്ലെങ്കിൽ ഇപ്പോൾ ഒരു സന്തോഷമില്ലെന്നാണ്.
എനിക്ക് ആദ്യമായിട്ട് നന്ദി പറയാനുള്ളത് ഷാജൻ സാറിനോടാണ്. ഷാജൻ സാർ ഇത്രയും ദൂരം വന്ന് നമ്മുടെ ഇൻവിറ്റേഷൻ സ്വീകരിച്ച് ഇവിടെ വന്ന് ഇതിന് എല്ലാ സപ്പോർട്ടും തന്നു. വളരെ നന്ദി സാർ. പിന്നെ കുര്യ ഉമ്മ സാറിന് പ്രത്യേക നന്ദിയുണ്ട് സാർ. താങ്ക് യു കമ്മിങ് ഹിയർ ആൻഡ് സപ്പോർട്ടിങ് അസ്. പിന്നെ ഡേവിസ് പോൾ സാറിൻ്റെ കാര്യം പിന്നെ പറയണ്ട. സാറ് എപ്പോഴും സപ്പോർട്ടീവായിട്ട് APT ഇത്രയും ഒരു നിലയ്ക്ക് എത്തേണ്ട എൻ്റെ മെയിൻ കാര്യം സാർ തന്നെയാണ്. പിന്നെ നമ്മുടെ സാറ് തോമസ് വടക്കൻ സാർ തന്ന ഒരു ഗൈഡൻസും, പിന്നെ പാസ്റ്റ് പ്രസിഡൻറ്റ് നമ്മുടെ ജൂഡോ സാറ്, റെന്നി സാറ്, പിന്നെ ഉണ്ണി സാറ്, എല്ലാവരുടെയും ഒരു ഗൈഡൻസ് കാരനാണ് ഇപ്പോൾ ഞാൻ ആദ്യമായിട്ടാണ് ഞാൻ ഒരു ഓർഗനൈസിങ് സെക്രട്ടറി എന്നുള്ള നിലയ്ക്ക് ഒരു പ്രോഗ്രാം കണ്ടക്ട് ചെയ്യണത്. അപ്പോൾ താങ്ക് യു മൈ സീനിയർ ഫാക്കൽറ്റീസ്. അപ്പോൾ ഇനിയും ഇതുപോലെ നല്ല കോൺഫറൻസസ് നമുക്ക് ഭാവിയിൽ നല്ല രീതിയിൽ നടത്താൻ സാധിക്കട്ടെ എന്ന് ദൈവത്തിനോട് പ്രാർത്ഥിച്ച് ഞാൻ ചുരുക്കുന്നു. താങ്ക് യു.